more. And that is important when we move ahead to explain why our data may be different than other settings. Before we move ahead, it's worth noting several things about Israel. First, all the residents are covered by 4 HMOs with comprehensive electronic medical record. The second point is that we have large PCR testing capability in Israel, so we are basing all our data on PCR and not really rapid antigen testing. And 2 things that are allowing us to really monitor the effects of policy changes is that every COVID-19 test result, positive or negative, is reported online to the Ministry of Health. So we know every day how many people are tested positive and negative, and all vaccines given in Israel are reported online to the Ministry of Health. So our capability of doing really online vaccine effectiveness is comprehensive. So our third wave was mainly alpha variant, as you see, and we started seeing, we started sequencing Delta variant sometime at the end of March, but it was really rare. It was among people traveling abroad, and it was one at a time. But there was steep increase in Delta isolation, reaching over 98% of the cases seen in June. And at the same time, we started to see our 4th wave. We are now still in our 4th wave, experiencing the highest level of infection that we have seen so far in this pandemic. And this is despite widespread over 60% of doubly vaccinated individuals. And in the vulnerable population, over 85% they are doubly vaccinated. And once we saw that, we were trying to figure out what that tells us. We saw daily cases rose by more than tenfold in a month and a half. So from roughly 12 cases a day to about 1,000 in a month and a half. And what was more worrisome is that we saw severe active cases increase by more than tenfold in a month, and among them was 60% vaccinated individuals, fully vaccinated individuals. So at that point, we had to stop and ask the question exactly as the CDC officer said, is that a Delta issue or is that a waning immunity issue? We had some clue that it might not be the Delta variant, at least not alone with its effect, because we started vaccinating 12 to 15 years old with FDA approval, and they actually had a fresh vaccine, and amongst them we saw vaccine effectiveness of around 90%. So the majority of them were protected, but still you can't really say because of the age difference and everything. So the other question we needed to figure out was what about the waning, and does that play a role? And as Ron will describe now the analysis we did, we think this is a major part of our picture in Israel at least.
Okay, so good morning everyone. What I'll be showing you are the results of the observational analysis that we did in Israel, which is after a relatively short time since the vaccination campaign. In spite of the potential biases that we described in the 2 papers that regarding the analysis, as well as the relatively short follow-up time, we thought it was our responsibility to analyze the data as thoroughly as we could and share it with the world through peer review. And this is what I'll be presenting today. So this is a bit of a heavy slide or complicated slide. It would be great if I also get a cursor at the bottom. But I would say let's try and follow in the following way. Let's start from the x-axis. We can see 3 cohorts, and we'll be focusing initially on the cohort on the right, ages 60 and above. On the y-axis, you'll see the confirmed infection rate per 1,000. We'll be talking about rates of SARS-CoV-2 confirmed infections. This is both symptomatic and asymptomatic based on PCR results. And I'll be talking here about people that were confirmed in the month of July. So as Sharon was saying, this is vastly dominated by the Delta variant. And the different shades that you see here refers to what happened for people that were vaccinated at different times. Starting from the dark colors would be January, meaning the ones that vaccinated early in the campaign. Okay, great. I got a cursor. Good. So you can see here, this is in the beginning. And then you can see we're proceeding here based on the month of vaccination from 6 months prior to the study period up to 2 or 3 months from the study period. And I think you can see that there is a change in the rate of confirmed infections per 1,000 people. And this is seen both at the age of 60 and above, which is what you see here, some monotonic change. And you can also view what happens with the other age groups. At the other age groups I do want to mention, you see the ones that vaccinated earliest tend to be healthcare workers or people at risk, mostly severely immunodeficient people, and therefore this should be interpreted with caution. But you can see a signal of waning both at the other both other cohorts that we interpret as the waning effect. You can also see here what happens in terms of waning immunity in relation to severe disease in the ages 60 and above. The y-axis is again regarding rates per 1,000 individuals in the study period in the month of July. All of those, or 99 or whatever percent, are the Delta variant, because this is what by far the most dominant. You can see that the confidence intervals, these are 95% confidence intervals, you can see that they are larger now. This is because the number of cases is smaller. I would mention that we have here over 1 million people that are being analyzed, so I would say it's not easy to get very small confidence intervals for these studies, even though the study group is very, very large. And you can see the change in rate through time. All of this, by the way, is publicly available. We made it available on the archive, and it's in the final stages of being published. Here we were asked to also present what happens in the younger age groups. This is mostly preliminary data. And you can see the ages 50 to 59, 40 to 49, and the younger age groups. The numbers are much smaller because the rate of severe disease is smaller. And therefore, the statistical confidence is also not as strong. And one could see the general potential trend, but it is hard to conclusively interpret it given the relatively small numbers. We do see what could be indications of a trend, but it depends heavily on how you want to also interpret what happens with the medical healthcare workers that were vaccinated in the month of January. There is an important point here that I want to mention that was an issue in Israel in trying to think about this. We saw in the CDC presentation and the following presentation, they were mentioning the issue of high degree of protection that you get from the vaccine for severe cases. And I want to just take a minute to show something that I found that was confusing in some of the discussions for us. There's no doubt that the vaccine gives good protection, meaning much better than not having the vaccine, and this has been shown in many different ways, and we observe it as well. At the same time, you could have high protection of, say, 97%, or you could have high protection of 85%. So 97% is what has been published, what is observed for against severe disease. 85% was mentioned in some of the previous slides and also concurs with what we seem to be seeing right now of the Delta for those that were vaccinated relatively early, meaning half a year ago. And while 85% might still seem very high, and this is only a 12 percentage point difference, I just want to point out that this translates the 97% vaccine efficacy means 3% relative risk, whereas 85% vaccine efficacy is 15% relative risk, meaning a 5-fold increase in relative risk, which is a very large increase, a fold change in the number of severe cases vaccinated, doubly vaccinated severe cases that have to be taken care of in the Israeli hospital system, and this is in line with the values that Sharon was mentioning, of what we saw, the sharp increase, over half of it in vaccinated people. So based on the evidence of waning in Israel and the trajectory exceeding national hospitalization capacity given the rapid rise in severe cases, Israel decided to begin a third vaccination campaign on July 30th, starting with the elderly. And I want to show you what we found regarding the effect of those boosts. So here is just the outline of the temporal campaign. So as I said, we started at the end of July, beginning of August, and there's been about 1 million doses given for the ages 60 and above. And you can see also the other cohorts, starting with the 50 plus 2 weeks later, and then 40 plus, etc. Altogether, we're close to 3 million booster doses that were given to date. You can see it here as a fraction of the eligible population in each cohort. The eligible are the ones that got 2 vaccines. They were eligible to take the 3rd vaccine, assuming it was over 5 months in our case. And you can see that a significant fraction of the population took it, and you can see that it started mostly with the elderly, and that made us do the analysis for that age cohort, which is where we have the most follow-up time. You can also see here the fraction of those eligible that were vaccinated with the 3rd dose to date. Overall, we're talking in the age of 60 plus that were included in the study. We're talking about 1 million people altogether, in which there were about 13,000 confirmed infection in the study period in August. We are still in the midst of a wave, and therefore there's a lot of cases. Okay, just before I get to the results, let me show you what we might be expecting, or the form of the results I'll be showing you. On the x-axis, I'll show you the date for vaccination. And on the y-axis, I'll show you the fold reduction in risk compared to 2 doses. So throughout the study, for many reasons, for example, that were mentioned in the previous presentation, we're sure to compare between those that already took 2 doses and those who decided to also take the 3rd dose, and compare between those 2 groups and not the unvaccinated, which might contain some potential confounders. In the beginning, also as was mentioned before, there could be all sorts of possible transient biases. In the days just following the 3rd dose, people usually, and we see the signal, there's a tendency to go and do less PCR tests for COVID-19. But then we see that decreasing, and then we're looking at the time period of about 12 days onward, which is the time scale in which we're expecting to see the effect because of 2 reasons. One is because we know that there is time until the neutralizing antibody response increases. That's usually on the order of a few days or a week. And then there's also a time between whenever you're infected or get protection from infection and the time this is observed through a test in PCR. That's on the average in Israel about 5 days, strongly related to the incubation period for developing symptoms, or just in general, also when you look at contact tracing, etc., that's roughly 7 days plus 5 days, so 12 days is roughly what you're expecting to see the effect being observed. So here are the results. Again, this is on the x-axis, you can see the time of infection, and on the y-axis, you can see, and on the y-axis, you see the fold reduction in the rate, again, compared to the 2 doses. All of this has also been publicly available, and now, we gave the slide as requested 3 days ago, but by now it's also published in the New England Journal of Medicine. All the results I'll be showing you are based on Poisson regression in order to take into account as many of the confounders as we could. It's adjusted for age, for gender, for demographic group, for the time at which the 2nd dose was given, and the calendar there. Just as was mentioned before, that these 2 temporal effects should be taken into account. And we'll be comparing, when we're talking about protection, in the main analysis, we're comparing between what happened 12 days onward versus what happened with no booster, meaning only 2 doses. Here is a summary of the results. We gain an estimated protection of about 11-fold. You can see that the confidence intervals here are relatively small, somewhere between 10 and 12, as a result of the many risk days that go into the analysis, and the fact that there's over 1,000 infections in this group over those 10 million risk days, and about 5,000 infections, or some 4,000 infections in the 2-dose only, no booster group. The rate difference is about 86.6 per 100,000 person days. These are the results for the age 60 and above. We also have preliminary results for the ages 50 to 59, and you can see a consistent picture where after about 12 days, we're seeing about a 10-fold protection. Similarly, for the ages 40 to 49, we're seeing, again, something like 10-fold decrease, 10-fold protection, again, doing the same kind of Poisson regression adjusted for all of those aspects. We understand the importance of doing this analysis as thoroughly as possible, and therefore we try to use different approaches. So what I showed you so far is based on the Poisson regression approach. We also use the matching approach, which is common in many of the studies for doing this. And when we're doing matching between those that got 3 doses to 2 doses, we got a very similar results in terms of the reduction in the risk. We also did another kind of analysis, being worried that maybe there are effects that we should account for just in terms of the behavior of those that only decide to take 3 doses versus 2 doses. And therefore, we took only those that took 3 doses. And as you can see here, we compared between those that were 12 days onward versus now the control group would be people that decided to take the 3rd dose, but we're looking at what happened to them 4 to 6 days following the booster dose. And we think that even under this analysis, we think that we're getting about 5-fold reduction, meaning significant protection also in this more stringent or conservative type of analysis. Let me move on to show you what we get for the severe results. Here you're seeing what happens for the ages 60 and above in terms of severe COVID-19 for the same study period. And we're seeing, again, a very significant decrease in the rate on the order of 10-fold or higher, and an absolute rate difference of 7.5 severe cases per 100,000 person days. Going back to the issue of Delta versus Alpha and waning, I want to point out that overall what we're seeing is we had in terms of confirmed infection, if after waning we're seeing something of the order of 50% versus the Delta, which is what is also observed in different studies from around the world, with a 10-fold increase, which is roughly what we're seeing, you get back to about 95%. Similarly, if you start from about 80% vaccine efficacy against severe disease, with a 10-fold increase, you get to about 97% or higher. And these are similar to the reports of what happens in terms of protection against the Alpha variant with the fresh vaccine. So overall, it seems like with the booster dose, we are getting again the protection that we originally got against the Alpha variant. And I want to point out that it's very hard to decompose what is the net effect that only comes from the waning or only comes from the difference between the Alpha and the Delta. What I've shown you enables us to do some of that, but overall I would say, even if you can't decompose exactly the effect, what we're seeing here is that in totality, the combination of both gives you the results that I just presented. I want to finish by just seeing what happens at the national level. This is what was the reproduction number R that we observed in Israel. And as you can see, throughout the month of June, and even before that, we were at about 1.3 to 1.4, which translates to a doubling every 10 days, which relates to what Sharon was saying about the fact that we had over a 100-fold increase in the prevalence. This is what happened following in the following weeks and months. We tried to reinstate the green passport, but that did not have a marked effect on the production number. And then with the booster campaign, with a delay that is roughly in line with what we expect, we started to see a continuous decrease in the reproduction number. You can see that this took a while, and therefore we had to make a decision also for the other age groups where we still had an increase in the numbers and the R was still above 1. This shows you, again, the effect at the national level. What you're seeing here as a function of time is what would happen to the number of new daily cases in terms of confirmation following the administration of the booster dose. This was for the ages 60 and above. And we're seeing that with a delay of about 2 weeks, we're seeing a decrease, whereas for the other ages where the booster dose was still not administered, we're seeing a continuous rise. This is in terms of confirmation. Here you can see the picture in terms of what happened in terms of severe disease. So we're talking about daily severe cases. You can see the booster dose being administered, and you're seeing that with a delay, you start to see a sharp decrease for those vaccinated versus those that were unvaccinated, in which the rise continued and did not go down significantly. Okay, Sharon. Sharon, you're on mute.
Thank you. You can see here the projection that we were looking at. The pink projection was based on no booster at all. And looking at the reproduction number, as Ron said, we were doubling every 10 days, and we got to places of thousands of cases, doubling every 10 days. It's scary. And the fact that we had roughly 1.5% of those confirmed cases turning into severe and critically ill patients. So you see here the pink line, which is the model we were looking at, that was based on the reproductive number, the cases, number of cases, confirmed cases that we had each day, and then how many of them would turn into being severe cases, and then accumulating them over time. And you see the purple one looking at a model taking into consideration a booster dose with 80% compliance rate. And the black line is actually the line of our data. So if we only looked at the model at the end of August, if we had not started booster doses at the end of July, we would have come to the capacity of Israel hospitalization capabilities and probably have gone beyond it. So 2,000 active severe cases that are hospitalized in hospitals in Israel is way beyond what we experienced in the third wave. Just to give it context, we were at 1,200 cases, and it was stretching. We had increasing mortality rate. It was a stretch. So this, we were anticipating at the end of August, 2,000 cases, active severe cases a day in the hospitalized. So what happened is with the booster dose, we were able to dampen that effect, and our severe cases now that are hospitalized are roughly 700 or less, and that has stayed stable, even though we still have days of 10,000 confirmed cases a day. So the other point, except for effectiveness and what we think is important to see with the vaccine, the other really important point is the safety. So I'm going to show you a few slides of the rate of events that are reported to the Israeli Ministry of Health. I want to emphasize from the get-go that we are sure to have underreporting, probably the same at every dose, but even if we have more underreporting at the third dose, we still would think that serious adverse events would be reported to us. And I will touch on myocarditis in a moment. But this is generally the the adverse events reporting to us from the first dose, the second dose, and now the third dose. And what we can clearly see is that for systemic adverse events, we didn't see any new types of adverse events, and the rate, to be modest, is at least the same, if not lower. And if we look at local adverse events, we would still see sort of the same trend. We don't see any new adverse events. We know that there's more lymphadenopathy, but we're not seeing any new adverse events, and the rate is smaller. Again, I say that with caution that it's probably underreporting. When our HMOs are doing direct calling people or sending them questionnaires, they get more than that. But I want to emphasize on the serious adverse event, because this is what is really important to us. And we had 19 serious reports following the third dose for more than 2.8 million booster doses administered, and each one of them is being investigated by an independent clinical work group using all the data from the hospitals, from the HMOs, to try to figure out if this is connected to the third dose or not. So what we have been getting is 7 reports on a serious adverse event following the third dose of the ages 12 to 64. You see how many vaccines it was, over 2 million. And we had 2 allergic reactions that are noted as connected to the third dose. We had a case of myocarditis in a male in his 30s who was hospitalized for 2 days and discharged. And we had a case of Guillain-Barré and Bell's palsy that is possibly connected to the dose. And then 3 cases of DVT, PE, TIA, CVA, and VT in a runner that happened during a routine stress test. All 3 of them was not deemed connected to the vaccine by the work group. And among 65 and above, you see over 800,000 vaccinees. We had 12 cases of serious adverse events. The first was suspected encephalitis, a guy who came in with fever and confusion. And for him, it was the second time it happened. It happened to him after the first dose. Did not happen after the second dose, but did happen again after the third. And that's a possible connection. A vitreous hemorrhage that is possibly connected. A CVA that is still under investigation. A bulk of cases, 4 or 5 cases that are infection origin, septic shock, thrombocytopenia due to sepsis, 3 cases of UTI and pneumonia that was deemed unconnected to the vaccine, and then 3 cases of mortality that was not connected, people with very multiple comorbidities that had reason for their demise. That was not connected to the vaccine. And so the myocarditis focus, I wanna emphasize first on this sentence. Most young vaccinees received a booster only in the last 2 weeks, so we don't have a full follow-up for them for 30 days as we want. We continue to follow them. Another important point is in Israel, because of the myocarditis, that was a signal. We saw it in the second dose of the vaccine. We saw increase in cases among young, mainly male, between the ages of 16 to 30. So you see here increasing cases after the second dose, and that was usually after the 4th or 5th day or during the 4th or 5th day after the second dose. So to some extent, we believe that some cases should have popped up in the 2 weeks follow-up that we have so far for several of the vaccines. But still, we need to be very cautious. We had only 1 case, as it said, of a 30-something-year-old male. In the myocarditis cases, we're actually doing active surveillance. So it's not just reporting to us. We are contacting each hospital every week to get all myocarditis cases, not just following vaccination. And so we feel here much more safe that it's not just under-reporting effect. And our last slide is really the summary. So the booster dose in Israel was effective and so far had safety profile similar to the other doses. We saw that the booster dose improves the protection by tenfold against confirmed infection, and at least for elderly against severe COVID-19. What we saw is basically that the post-booster efficacy against Delta was similar to the pre-waning efficacy against Alpha. It's like a fresh vaccine. And the adverse events were not more acute than the first or second, and we didn't see any new severe cases of adverse events. Based on the data that we continuously collect, we are presenting this to our Vaccine Safety and Effectiveness Committee, and they have approved by steps giving the booster dose after 5 months to people starting from 60 and then 50 and then 40. And so we are rolling now in the vaccination campaign, and administration of the booster dose helped Israel dampen severe cases in the fourth wave. Thank you for your attention.
And thank you both so much for these valuable data. I was about to ask a two-fold question, which I usually don't like to allow, but first about myocarditis, but you presented very carefully information, including the fact that younger individuals really have not been heavily vaccinated as yet. So the age is there, the age cutoff is hard to determine. One point of information, the second dose in Israel with the Pfizer-BioNTech vaccine was typically given after 3 weeks or delayed?
Yes. Yes, so we started the vaccine campaign after the FDA approval, exactly by the protocol approved by the FDA with 3 weeks apart.
Okay, thank you. Dr. Pergin.
Thank you very much. That was a really thoughtful set of slides, and we really appreciate you sharing with the committee. I had a question specifically. It seems like you have an opportunity to look at demographic differences between individuals who were eligible to get vaccinated with the booster but didn't. The group that only received 2 doses versus received the 3. Do you find any demographic differences? You have a really robust medical record, and I'd be really curious to know, are there differences that might suggest maybe that the group that received the booster were either higher risk or did differential levels of protection in that?
Yes, so I would say we definitely looked into this, and there are differences which we account for in both in the Poisson regression as confounders and in the matching approach also as confounders. We see them, for example, in terms of the tendency to take the third dose, which is different among different demographic groups in Israeli society, among different age groups, and this is all reported in the paper that was published. You can see in the tables there are really significant differences, but all of those are supposed to be accounted for inherently in the way we're doing the analysis.
Dr. Kurilla.
Thank you, Arnold. See if my camera is actually working this time. Nope. Okay. There we go. Yes, it is now.
We see you too.
Thank you for the presentation. Very, very, very insightful. One of the things that stands out for me from your data is that the waning of immunity, which seems to be more waning of immunity rather than a Delta-specific phenomenon, although there may be a small component, it would seem that one would have to conclude either that the mRNA vaccine in general, that platform, or else the shortened dosing interval does not really, between the 2 doses, does not lead to long-term good durability of the immune response. And those individuals at risk, particularly for severe disease, don't have a good cell-mediated immune response and are relying entirely on their neutralizing titer and other serology, which is dropping off rather quickly. Your boost clearly does that. So my question to you is actually twofold. One, although it's very early, do you have any evidence that the 6-month boost is actually contributing with a better dosing interval to give you more long-term durability in the immune response? And is there any change in the kinetics of the antibody response, or do you anticipate that just every 6 months you're going to have to keep boosting these people?
So I'll start with the end of your question. I think this is very early. We can't really tell. We know from other viruses that sometimes, like in hepatitis, you get a dose, and after a month a dose, and after 6 months a booster, and you have protection for many, many years. Whereas for influenza, we need to be vaccinated every year, and I think it's not really clear where this is going. We definitely don't have any plans at the moment to boost every 6 months. We'll base it exactly as we did here, based on the results. We'll continue to monitor and see if there is, again, any waning effect. But it may be that we won't see that after the booster we'll have a higher protection for a longer period of time.
I would add that I think that the effect of the Delta versus Alpha is not very small. I think they're both very significant, both the Alpha versus Delta and the waning. And there's also maybe an interaction, a synergistic effect from both of them together. So I wouldn't think about it as a small effect.
Thank you.
Dr. Levy. And quick questions and quick answers, please. We're going to have time to come back again later.
Hello. I'd like to thank the presenters for a wonderful presentation and impressive progress. One question I had was related to the decision to give boosters to the younger individuals as well. As we know, there is some increased risk of myocarditis, particularly in younger males, and it seemed like there was relatively less data in the younger age groups. So what were the considerations from a policy perspective of recommending a booster for that youngest group? If Dr. Elroy-Priest can say a few words, I'd really appreciate it. Thank you.
Sure. So first of all, we know from research done by Clalit HMO in Israel that the risk of myocarditis from corona itself is higher than the risk from the vaccine. And when you have really roaring pandemic with a surge of thousands of cases and doubling every 10 days, the risk of people, even young people, to be infected with corona and get the myocarditis is higher than being vaccinated. And that risk, and I have to say that there is a work being published or in the review process from Israel about myocarditis, and in 95% of the cases, the myocarditis was not severe. And so we feel that when we weigh a pandemic roaring with, we saw reproductive number of over 1.3, doubling every 10 days, the risk even for the young adults would be higher. And I have to say something about a mix of our population. So if we only vaccinated the 60 and above, this is roughly 16% of our population. Most of our population is younger. And when we looked at the cases, confirmed cases that we had in the fourth wave, 15% of them were 60 and above. So the majority was not the 60 and above, and we believe we wouldn't be able to control the pandemic just by vaccinating those 60 and above. When you have roaring pandemic and we know that the numbers are doubling, then we really have to make sure that we get to a reproductive number of under 1 in order to control this. And we wouldn't have been able to do this, we think, just by vaccinating the 60 and above.
And any sense of
we're going to have to move on.
Okay.
We've got a list of about 8 people who want to ask questions. Dr. Gans. Go ahead, please. Dr. Gans? We're going to have to go on to Dr. Rubin until
Sorry.
Dr. Gans.
Sorry.
Okay, okay, Dr. Gans, quickly.
Thank you. This is wonderful and very provocative given that you were ahead of us and so foreseeing the future. So thank you for sharing your data. I had a question because not only, and as you suggested in your last answer, in order to really control a pandemic, we actually have to control secondary cases, so the ability to spread. And what we are starting to see is in our vaccinated households, we are starting to see spread into our younger populations who are no longer seemingly protected by, herd immunity around them. Were you able to look at the secondary cases within households? You have the opportunity to do that. People are getting tested. So what is the lack of protection for children when you started seeing those surges, and then was there any control of that protection to those in our societies who haven't been able to be vaccinated?
Quick answer to a complicated question, please.
We'll do our best. Our fourth wave actually started with younger people coming from abroad, and their kids. The older adults were vaccinated. The kids obviously were not, and we saw a surge in cases among both. And that was the beginning of our fourth wave in kind of two spots and then spread in a community way. What we saw at the beginning of June is that the ability of a vaccinated individual to spread it to others was lower than the non-vaccinated. So roughly 80% of the people who were vaccinated at the beginning, did not infect others outside their household. In their household, it was highly contagious. So vaccinees that became confirmed cases were infecting their household, and that actually led us to a policy that said if you have a confirmed case at your household and you need to take care of him, a child, you can't really go in and out taking care of him because you'll be infected and you'll infect others going to work. So we definitely see that cases that are vaccinated, doubly vaccinated, that are no longer fresh, what we call more than 6 months from the second dose, are infecting other people. It's obviously less than non-vaccinated, but we're seeing that, especially in their household.
Dr. Rubin, the final question before we are forced to take a break.
Thanks, Arnold. Thank you very much for the presentation and for generously sharing the data. The Israeli data are very important for all of us making these decisions, so you're in a great laboratory and you've done a very nice job of it. Dr. Gans just mentioned how one of the goals would be to prevent transmission and reduce the size of the epidemic, but of course, another goal is preventing severe disease. If you look at it through that lens, can you identify the people who are likely to get severe disease? Do they look like the people at high risk otherwise? In other words, could you focus the administration of a third dose of vaccine on particular groups to give a very high yield for preventing severe disease?
So the obvious question is those who are 60 and above and those who have comorbid conditions, especially morbid obesity. We see that as a very clear chronic disease that is a risk factor for COVID-19. However, as I said before, having about 60% of the population over 60, it's really we can't imagine just vaccinating that group, knowing that 85% of the confirmed infections are among the rest of the population, and trying to get to a reproductive number of under 1 so this pandemic starts to shrink, this wave will start to fall. we have to, in our opinion, in Israel, we had to vaccinate more than just 16% of the population to get there. So we definitely see mortality among young people who are not vaccinated, 30, 25, 41, really young people. And we started to see the same trend of severe critically ill patients among those who are 40 to 60 and have been doubly vaccinated. And we just didn't want to wait to see those results, and we knew that we needed to vaccinate a larger proportion of the population in order to get the numbers down quickly. And I have to add one more thing. We always look at the severe and critical disease status or mortality. I think there is also importance in long COVID among those who are infected. And so we can't really put this aside and say, you know, this is influenza. If you went through this, it's fine. We see that there is a high percentage of people, including young people, who are left with symptoms for over months. So there are several reasons why we wanted to make sure that we overcome this fourth wave.
Okay, thank you so much. A very good and very informative presentations and a very vigorous discussion, which actually will be continued in the question and answer session, which comes later. And I hope our speakers from Israel, especially where there's a 7-hour time difference, will be able to stay with us, and from the UK as well, for that discussion later on. So 5 minutes for a break, and then we resume again.
Thank you.
Well, welcome back to the 167th VRPAC meeting. We will get started with, that was a nice little short break, and I will hand it back to Dr. Monto. Take it away.
Thank you, Mike. We're about to move to the sponsor presentations. We're going to be hearing about the effect of the booster shot, and we're going to be listening to presentations from Donna Boyce, Senior Vice President, Global Regulatory Affairs at Pfizer, and from Dr. Bill Gruber, Senior Vice President at Pfizer. Take it away.
Good morning, members of the committee, FDA, and ladies and gentlemen in the audience. It's a pleasure to be here today. I'm Donna Boyce, and I'm the Senior Vice President of Global Regulatory Affairs for Pfizer. I would like to thank the FDA for organizing this VRPAC and the VRPAC chair and members for their time. Pfizer and our partner BioNTech are pleased to be here today to discuss a revision to the dosing schedule for our mRNA COVID-19 vaccine. Our presentation today will follow this agenda. After I provide a brief introduction, Dr. William Gruber, Senior Vice President, Vaccine Clinical R&D, will review the booster clinical development program, including the neutralization data from Phase 1, the Phase 3 immunogenicity and safety results, the pharmacovigilance plans, real-world evidence supporting the use of a booster, and a benefit-risk conclusion. After this, I will come back to provide conclusions for our presentation. The Pfizer-BioNTech COVID-19 vaccine, also known as BNT162b2, has been available for the prevention of COVID-19 disease in individuals greater than or equal to 16 years of age since December 2020 under an emergency use authorization, and in individuals greater than 12 years of age since May 2021. To date, 1.7 billion doses have been distributed globally. Between February and May 2021, and in accordance with FDA guidance, we conducted a pivotal clinical study to evaluate the safety and effectiveness of a booster dose. FDA granted full BLA approval of BNT162b2, also known as Comirnaty, on August 23rd for the prevention of COVID-19 disease in individuals greater than 16 years of age as a two-dose series given 3 weeks apart. The duration of protection following the two-dose primary series is currently unknown, but available data suggests that efficacy wanes over time. Based on the positive results of the booster dose study, available real-world evidence, and in consultation with FDA, on August 27th, we submitted a supplemental biologics license application to seek approval of a single booster dose after the primary series. There is substantial, randomized, controlled trial data and real-world evidence to support that vaccine efficacy wanes over time. As you heard earlier, recent data from Israel and the United States, in the context of the Delta variant of concern, suggests that vaccine protection against COVID-19 infection wanes approximately 6 to 8 months following the second dose. A retrospective real-world evidence cohort study conducted at Kaiser Permanente, Southern California, suggests that the observed erosion in vaccine effectiveness is likely primarily due to waning effectiveness rather than due to Delta escaping vaccine protection. Waning effectiveness over time is further supported by a recent FDA-requested post-hoc analysis of breakthrough cases in the pivotal Phase 3 efficacy study. To demonstrate the safety and effectiveness of a booster dose against COVID-19, Pfizer and BioNTech conducted a sub-study of the Phase 3 pivotal study that complies with the FDA guidance. The results of this study demonstrate that a booster dose of BNT162b2 has an acceptable safety profile and elicits robust immune responses. Finally, real-world evidence from a recently initiated booster vaccination program in Israel that we just heard, in the face of waning immunity and in the period when the Delta is the dominant vaccine, shows a booster dose has a reactogenicity profile similar to that seen after receipt of the second primary series dose and restores high levels of protection against COVID-19 outcomes. The booster study was conducted in individuals 18 to 55 years of age, as recommended in the FDA guidance. The study was conducted in 2 phases. Phase 1 demonstrated that a booster dose administered approximately 6 months after the second vaccination of our vaccine had an acceptable safety profile and elicited robust immune responses against the wild type as well as the beta and delta variants of concern. Phase 3 showed that the vaccine was as well tolerated as the second primary dose and elicited immune responses against the wild type variant that were non-inferior to the immune responses observed after the second primary dose, meeting the protocol-specified immunobridging success criteria for GMTs and seroresponse rates. Moreover, and in accordance with FDA guidance, the safety and effectiveness of the booster dose in individuals 18 to 55 years of age can be extrapolated to individuals 16 and 17 years of age and over 55 years of age. These data serve as the basis for the supplemental biologics license application. During the remainder of our presentation, we will share data with you that demonstrate that the overall benefit risk of the booster dose is favorable. Specifically, that the demonstrated safety and effectiveness of a third dose support adding a booster dose to the vaccination schedule. And the global real-world evidence demonstrates that the reduction in vaccine efficacy is likely due to waning effectiveness and supports that a booster dose can restore high levels of protection with an acceptable safety profile. Based on these, we're requesting licensure of a single booster dose of BNT162b2 administered intramuscularly at least 6 months after the primary series in individuals greater than 16 years of age. I will now turn our presentation over to Dr. William Gruber, who will present clear and compelling data demonstrating the booster safety, immunogenicity, and effectiveness. Bill?
Thank you, Donna. It's my pleasure to share with you today the clinical program that supports the safety and effectiveness of a booster dose. I have 3 goals in my presentation this morning. First, I will speak to the public health need that could be well served by a booster. Second, I will describe the clinical trial and real-world effectiveness data supporting the safety and effectiveness of the booster dose. Third, I will conclude with overall benefit risk of a booster dose. Let's begin. There is clear erosion of vaccine protection over time against COVID-19, and emerging data indicates loss of protection against hospitalization. We need to maintain high vaccine effectiveness against COVID-19 to contain the pandemic. A safe and effective Pfizer-BNT vaccine booster dose for individuals 16 years of age and older would be expected to restore protection and reduce COVID-19 illness and spread. The BNT162b2 vaccine is highly protective against COVID-19, but the duration of protection wanes over time. Let's talk about the lines of evidence supporting this claim. First, data from the pivotal phase 3 clinical trial showed that 2 doses of the Pfizer-BioNTech vaccine administered 3 weeks apart confers protection against both symptomatic and severe COVID-19. That, of course, was the basis for the emergency use authorization and the recent licensure of the COVID-19 vaccine in individuals 16 years of age and older. The full duration of protection of the Pfizer-BioNTech vaccine is currently unknown. An analysis of efficacy up to 6 months after dose 2 from the pivotal clinical trial shows that initial vaccine efficacy slightly wanes over time in the pre-Delta period from 96.2% in the first 2 months after vaccination to 90.1% over 4 months, and is still sustained at 83.7% up to approximately 6 months. Further waning of immunity and protection over time has been observed across the world, coinciding with penetration of the Delta variant. Originally observed in Israel, as you heard, this is now being observed in the United States and elsewhere. As we all know, The Delta variant became widespread globally as of June and July of this year. Reports describing reduced effectiveness of the Pfizer vaccine and other COVID-19 vaccines against SARS coronavirus 2 infections caused by Delta have surfaced from Israel, the United States, and Qatar, as you've also heard earlier this morning. Recently in Israel, reduction in vaccine effectiveness has been observed against hospitalization and severe infection over time after a 2-dose Pfizer vaccine primary series. And again, you heard details about this earlier today from the Israeli Ministry of Health. In addition, recent U.S. CDC data hint at reduced COVID-19 vaccine effectiveness over time against severe disease and hospitalization in the U.S. This reduced vaccine effectiveness tracks with longer spans of time between 2 doses of vaccine and SARS coronavirus 2 exposure. Vaccine effectiveness studies to date have not adequately differentiated the impact of Delta from potential waning immunity on recent reductions of vaccine effectiveness. In collaboration with Kaiser Permanente Southern California, Pfizer evaluated overall and variant-specific real-world effectiveness of the Pfizer vaccine against SARS coronavirus 2 infection and COVID-19 related hospitalizations by time since vaccination. This was done to further inform issues of waning immunity and protection. So let's first take a look at the methods that were used in the Kaiser trial that informed thinking. The setting is the Kaiser Permanente Southern California group, which includes over 3.4 million members greater than 12 years of age who would be potential vaccine recipients. The study period includes December of 2020 through August the 8th, 2021. This encompasses both the period when first the Alpha and later the Delta variants were present. Whole genome sequencing has been done on all samples obtained during this period as part of this trial. A cohort approach was used using Cox models. And again, this looks for both outcomes of infection as well as COVID-19 related hospitalization as defined in the footnotes shown at the bottom of the slide. The vaccine status was evaluated with those fully vaccinated with 2 doses of vaccine at least 7 days after the second dose. This also looked at attack rates in the unvaccinated as a comparator. Here's the first key observation. Vaccine effectiveness waned over time against infections, but as of this summer, had not yet waned against hospitalization in the Kaiser Permanente study. So let me describe for you the data that supports these observations. If we start on the left-hand side, you see the graph titled SARS coronavirus 2 infection. On the x-axis are represented months after full vaccination, and on the y-axis, adjusted vaccine effectiveness. Each of the colored lines represents a different age group from 12 to 15 years of age, up to adults 65 years of age and older. The black line represents all individuals 12 years of age and older. Vaccine effectiveness against circulating virus at each time point is shown as a corresponding number above the x-axis. Vaccine effectiveness was 88% in individuals 1 month after 2 doses of the Pfizer vaccine in this study. As you can see, for all age groups 16 years of age and above, efficacy wanes over time, dropping to 47% for those individuals out more than 5 months from completion of the 2-dose series. For 12 to 15-year-olds, efficacy may be somewhat better sustained, perhaps consistent with higher virus neutralization levels achieved in this age bracket. However, follow-up is of shorter duration due to the more recent approval of vaccine for this age group. If we look on the right-hand side, we see, in contrast to effectiveness against infection, effectiveness against COVID-19 related hospitalization has been sustained over this period of time in all age groups from 12 to 15 years of age to those over 65 years of age, out to at least 5 months. You can see that the efficacy for those vaccinated at less than 1 month is 87%, and for those vaccinated at greater than 5 months is still around 88%. Now, please keep in mind what you've heard earlier from the Israeli Ministry of Health. effectiveness against severe disease and hospitalization has begun to decline in Israel. The combination of early comprehensive immunization and a high proportion of the population more than 6 months post-vaccination in Israel may have contributed to this early signal in Israel. These results, along with recent CDC data, portend that effectiveness against COVID-19 hospitalization and severe disease are less likely to remain sustained in the future in the U.S. We may see similar increases in hospitalizations and severe disease in weeks to months for those individuals vaccinated early in the U.S. campaign. If so, the time to restore protection with a safe and effective booster dose of BNT162b2 is now. It's important also to look at the relationship between vaccine effectiveness and the variants that are circulating. And a second key observation from the Kaiser study becomes clear. Vaccine effectiveness wanes over time irrespective of the variant of concern. What is the evidence to support this claim? Again, the orientation of this slide is much the same as you saw previously. Months after full vaccination are shown on the x-axis, and adjusted vaccine efficacy is shown on the y-axis. Whether we examine other sequenced SARS coronavirus 2 variants, represented by the black line, or the Delta variant, shown in the blue line, the vaccine effectiveness over time wanes. Point estimates of vaccine effectiveness are lower for the Delta variant after completion of a 2-dose vaccine series, but a number of the confidence intervals overlap. Most prominently, comparative data shown here supports that declining immune response over time is the primary driver of vaccine effectiveness and not variant escape. Restoration or improved immune response by a booster BNT162b2 dose would be expected to restore the comparable high protection against Delta and other variants seen at the left end of the graphs. We also have additional information gleaned from the pivotal clinical trial that informs this thinking. This type of randomized control analysis was noted to be a best practice by Dr. Stern earlier today. It reveals waning protection between 5 and 10 months after 2 doses of the Pfizer vaccine. As shown in the top graphic, this evaluation was done in the pivotal phase 3 efficacy trial in individuals over 16 years of age who completed the 2-dose series early in the study, the original vaccinees, to participants who were in the placebo group that crossed over to the vaccine after the vaccine received emergency use authorization. This permitted evaluation of the difference in incidence rate and relative protection against COVID-19 for those who received vaccine proximate to the Delta surge, the crossover group, versus those who received vaccine more remotely, the original vaccinees. The text at the bottom, beginning on the left, describes the results. The mean time from dose 2 to July the 1st is 4.7 months for the crossover group and 9.8 months for the original vaccine group, providing a separation in time that allows one to differentiate a potential effect of this parameter on immune response and protection. 90% of the crossover group received dose 2 less than 6 months prior to July the 1st, and almost all in the original vaccinee group received dose 2 more than 8 months prior to July the 1st. Relative vaccine efficacy comparing those immunized later compared to those immunized earlier was 26.3%. If we assume for a moment that protection against COVID-19 falls below 70%, which is reasonable based on trial data as well as the Kaiser data I've shared with you, and that it falls below 70% at 5 months after vaccination, efficacy by extrapolation would be expected to be below 60% at 10 months compared to those that were unvaccinated. Difference in incidence rates calculate as 18.6 cases per 1,000 person years of follow-up. And the magnitude of this risk highlights the public health importance of time when one extrapolates this to the millions of individuals who may remain at risk in the setting of Delta variant or other variant spread. Over a year's time, 1.86 million more cases might be expected to occur in 100 million individuals similarly exposed over a year who are 10 months out from a 2-dose series compared to those 5 months out from a 2-dose series. A safe and effective booster dose of the Pfizer-BioNTech vaccine would be expected to narrow this gap. So let me summarize then the public health need that leads us to conclude that a safe and effective booster would be beneficial. Israel and the United States real-world evidence suggests that vaccine efficacy against COVID-19 infection wanes approximately 6 to 8 months following the second dose when the Delta variant is predominant. A retrospective Kaiser study suggests that vaccine efficacy reductions are primarily due to waning vaccine-induced immunity rather than due to Delta escaping vaccine protection. Waning vaccine effectiveness is further supported by the recent FDA-requested post-hoc analysis of breakthrough cases in the pivotal Phase 3 clinical study. While waning vaccine efficacy against hospitalization was not observed in the United States, this should be carefully monitored, as data from Israel suggests that reduced effectiveness against severe disease could eventually follow reductions in vaccine effectiveness against SARS coronavirus 2 infections. The Israeli experience could portend the U.S. COVID-19 future, and soon. So the information I presented to you speaks to the importance of waning protection and a compelling rationale to restore protection. What information do we have that reassures us about the safety and potential effectiveness of a booster dose to meet that need? I'm going to share that with you now. First, it is important to understand the nature of responses across not only the current variants of concern, but variants that may be of concern in the future as we contemplate the advantages of a booster dose. For this, information that we have after 2 doses of the Pfizer-BioNTech vaccine are reassuring. The vaccine-elicited sera effectively neutralize a broad range of SARS coronavirus 2 spike variants after 2 doses of the Pfizer-BioNTech mRNA vaccine. And you can see this is true whether we're talking about the wild-type variant, the previously prominent alpha variant, the beta variant, or the more recent Delta variants. I would highlight that even in a circumstance associated with the lowest response seen here, a GMT of 194 to the beta variant, efficacy was observed in the South African cohort from our pivotal trial. You will recall that we demonstrated a case split of 0-9 vaccine versus placebo, 8 of whom had a specimen successfully sequenced to reveal that the virus was the beta variant. So this provides the following reassurances. So far, immunologic escape from serum neutralization after 2 vaccine doses has not been demonstrated. Given that a second Pfizer-BioNTech vaccine dose is associated with robust antibody responses across variants of concern, increased responses to vaccine virus, what we reference as wild-type virus, after a 3rd dose should also be associated with increased neutralization response to variants of concern. I will share with you evidence that supports this logic. First, I want to remind you about the original pivotal study design, which was used for us to examine a booster dose. This slide may look familiar to you because it's similar to what was presented at the time of emergency use authorization. The vaccination period for the purposes of this trial for the 2 primary doses were 21 days apart. As you can see represented on the graph, individuals had active surveillance performed to look for COVID-19 illness in association with nucleic acid amplification test positive evidence of SARS coronavirus 2 infection. As you can see, the length of times that were used to follow up for reactogenicity is shown in the green, 1 month for non-serious AEs, 6 months for serious AEs, and up to 2 years for deaths occurring in this population, including older adults and those with comorbid conditions. Now, I want to share with you where we are today. This graphic represents the experimental design of a third dose of vaccine administered to individuals recruited from the phase 1 and phase 3 phase of the pivotal safety and efficacy trial. Again, we took the population who had received their original 2 doses 21 days apart. For phase 1, we went to the sentinel cohorts who were first immunized as part of our trial in May of last year, which represented 23 individuals, and administered a booster dose, obtaining the safety information as well as serum samples to measure immune response over the time periods shown. Lighter blue represents days, darker blue months. After we gained sufficient information from phase 1 that reassured us about the safety and immune response to the vaccine, we then moved to the expanded group that recruited from the phase 2-3 portion of the pivotal trial. So these individuals were now approximately 7 months post-dose 2. There were 312 of them in the group who were boosted. And again, we tracked reactions, adverse events, and obtained blood specimens as shown to monitor safety and immune response. So let me summarize for you first the data from the phase 1 part of this trial. I'm going to begin with the immunologic responses. Post-dose 3, BNT162b2 indicate a substantial boost and reduced gap between the wild type and beta neutralization with the boost. The beta variant was chosen at the time because of concern about potential for a spread and as a surrogate for other variants. So let me now share with you the evidence that supports this statement. First, let's examine the 18 to 55-year-old group on the left-hand side of the slide. The x-axis represents the time of dosing and measurement of antibody response, and the y-axis represents 50% serum neutralizing titer to SARS coronavirus 2. If we begin with those individuals who received 2 doses of vaccine, the primary series, you can see that for both the wild type and the beta variant tested in this trial, that there were robust antibody responses that were most prominent 7 days after dose 2. These began to decline as soon as 1 month after dose 2 and were still lower before dose 3. If you then look at the response after administering the booster, there are at least 3 important observations. Number 1, there is a dramatic increase in the antibody response as measured by GMTs for both the wild-type virus as well as the beta variant at 7 days after dose 3, as well as 1 month after dose 3. Number 2, the difference between the response to the wild-type and the beta variant has narrowed, represented by the geometric mean ratio shown at the top. The ratio 1 month after dose 2 is 0.27. 1 month after dose 3, this ratio is 0.73. So we see a narrowing of the geometric mean ratio and therefore narrowing of difference between immune response to the wild-type vaccine virus and the beta variant after the 3rd dose. Number 3, in contrast to the decrease in antibody response seen 7 days after dose 2 to 1 month after dose 2, we actually see an increase in antibody response between 7 days after dose 2 and 1 month after dose 3. So what does all this mean? Our interpretation is that we're seeing a robust immune response that equals or greatly exceeds the response that we've seen after the 2nd dose. This response continues to mature as evidenced by a continuing increase in antibody response at 1 month and narrowing of the difference in geometric mean ratio between the response to the wild type and the beta variant. This bodes well for comparable and perhaps improved protection after a 3rd Pfizer-BioNTech vaccine dose. Again, on the right-hand side of the graph, these observations are recapitulated and perhaps even more important in the 65 to 85-year-olds. Why? Responses after the 2nd dose of vaccine tended to be lower and decayed more rapidly than in younger adults. But look what happens after the 3rd dose. Higher antibody response are seen 7 days and 1 month after dose 3 compared to those after the second dose, and closely rival those seen in younger adults. There is again narrowing of the GMR between wild type and beta variant and an increase in response over time. This suggests a significant immunologic benefit of a booster dose of the vaccine that is likely to confer similar or perhaps better protection than that provided by the second dose. This information was published in the New England Journal of Medicine this week. Now, of course, it's important to know, does this apply to the Delta variant, since that's the variant of current concern? I'm pleased to report the post-dose 3 Pfizer-BioNTech GMTs indicate a substantial boost to the Delta variant similar to that seen with wild type. This information is also included in the New England Journal of Medicine publication. Here we've represented for you the responses 1 month after dose 2 compared to 1 month after dose 3 with a similar scheme as shown on the prior slide. Younger adults on the left and older adults on the right. We again see a dramatic increase in immune response after the third dose as measured by virus-neutralizing GMTs to both wild-type virus and the Delta variant, and a narrowing of the GMR point estimates as shown at the top after the third dose. Note that this narrowing of response is most prominent in the older age group. This provides further reassurance that a third dose of vaccine is likely to provide immunologic benefit, restoring and perhaps improving protection against the Delta variant. Given the observations I shared with you earlier about lack of immunologic escape for variants tested to date after 2 doses, these observations inspire optimism about the potential for a high level of protection against current and future variants after a third vaccine dose. So what about reactions seen in phase 1? In the phase 1 cohorts of younger and older adults, the evidence was reassuring that local reactions by maximum severity within 7 days of the third dose, the bottom panel, were similar to those after dose 2, the top panel. The local reactogenicity captured by eDiary revealed no redness or swelling and comparable pain. Also, systemic events by maximum severity within 7 days after the third dose were similar after dose 3 compared to dose 2. We have found fever and chills to be the most discriminating common reactions. In the phase 1 cohorts, comparable levels of fever and a comparable level of chills were seen after dose 3 compared to dose 2. Other reactions were also comparable. This safety information, coupled with the preceding immune response data, gave us confidence that we could move forward into the expanded cohort. So let me now summarize for you the phase 3 portion of this booster study. To begin, I will describe for you how this phase 3 study was designed by Pfizer and approved by the FDA to support a booster dose indication in individuals 16 years of age and older. This FDA-approved approach is based on meeting predefined safety and immune response criteria in the 18 to 55-year-old age group with extrapolation to the full age range, 16 years of age and above. So what is the basis for extrapolation of phase 3 third dose data to 16 to 17 and greater than 55-year-olds? The FDA immunogenicity requirement is outlined in the text shown and referenced by the footnote. It reads, studies may be conducted in a single age group, for example, adults 18 to 55 years of age, with extrapolation of results to other age groups for which the prototype vaccine has been authorized. Meeting this requirement was judged by CBER as sufficient to submit immunologic data for a supplemental licensure of the Pfizer-BioNTech vaccine third dose. Regarding extrapolation of safety to the full age range, a few observations are pertinent. For 16 to 17-year-olds, similar reactions in this age group to 18 to 55-year-olds after 2 doses predicts that reactions would also be similar after the third dose. For adults over 55 years of age, local reactions and systemic events in participants greater than 55 years after dose 2 were lower than those seen in younger adults. This predicts lower reactions after the third dose in individuals greater than 55 years of age based on the favorable or better reactogenicity profile seen after the third dose compared to the second dose in 18 to 55-year-olds, data that I'll be sharing with you shortly. Now, to interpret these results in the context of what we're seeking today, it's important to understand the FDA immunogenicity criteria for a booster dose. The FDA guidance specifies that the booster dose must be adequately powered to demonstrate that the immune responses induced by the booster dose, serum neutralizing titers against SARS coronavirus 2, as measured by seroresponse rates and GMTs, are statistically non-inferior compared to those elicited by the vaccine in the primary series. So how do we do that? The success criteria include demonstration of non-inferiority margins of -10% for seroresponse rates and 1.5-fold for GMTs. Based on consultations with CBER, these criteria are also considered sufficient to support licensure of a booster following full approval of the primary series. This table shows the demographics of subjects receiving the third dose. These demographics are representative of 18 to 55-year-olds in the parent study. Note that we have a balanced representation across gender, races, and ethnicity. Over 50% of individuals had comorbidities as measured by the Charlson Comorbidity Index. The age of vaccination was approximately 41. The time from dose 2 to the booster was close to 7 months, with a minimum of approximately 5 months.
Your microphone has been turned on.
All right, Pfizer, you're back connected.
Okay, thank you. Let me maybe start a little bit back to make sure that everybody gets to hear what I had to say. So this table shows the demographics of subjects receiving the third dose. These demographics are representative of 18 to 55-year-olds in the parent study. Now that we have a balanced representation across gender, races, note that we have a balanced representation across gender, races, and ethnicity. Over 50% of individuals had comorbidities as measured by the Charlson Comorbidity Index. The age of vaccination was approximately 41. The time from dose 2 to the booster was close to 7 months, with a minimum of approximately 5 months and a maximum of 8 months since the 2-dose series. So let's look at the immune response data. Recall that the study needed to meet 2 immunologic criteria for non-inferiority based on comparison of geometric mean virus neutralization titers and seroresponse after the third dose to those responses seen after the second dose. The geometric mean ratio of neutralizing titers non-inferiority criterion post-dose 3 compared to post-dose 2 was met, with titers after the third dose approximately 3-fold higher than those seen after the second dose. This table shows SARS coronavirus 2 neutralization titers in 210 individuals, looking at 1 month post-dose 3 compared to the GMTs after dose 2. The GMR is the ratio of these responses. To declare success, the lower bound of the confidence interval for the GMT on the right side of the table needed to be above 0.67 or 2/3. We see that the lower bound greatly exceeds the success criteria at 2.76, with the GMR point estimate indicating responses were 3-fold higher after the booster dose compared to responses after dose 2. Hence, this meets not only the non-inferiority criteria, but indicates that the virus neutralization responses seen after the third dose are consistent with phase 1 results and greatly exceed and are statistically greater than those seen after the second dose. This figure demonstrates graphically the SARS coronavirus 2 neutralization GMTs with relationship to dose. GMTs shown are based on the number of subjects with valid results at each time point, while the non-inferiority analysis for the GMT ratio shown on the prior slide are based on subjects who had valid results at both 1 month post-dose 2 and 1 month post-booster. Time and doses are shown on the x-axis, 50% neutralizing GMTs on the y-axis. Results are consistent with those seen in the phase 1 study. Neutralizing GMTs rise to protective levels after the second dose, followed by a drop prior to the third dose. By 7 days after dose 3, observed virus neutralization GMTs are nearly double, and by 1 month are triple those achieved after the second dose. These results indicate that a third dose is likely to begin conferring benefit shortly after administration. Non-inferiority of the booster dose was also demonstrated based on proportion of subjects with a seroresponse meeting the second immune response licensure criterion. Seroresponse is defined as achieving a greater than or equal to 4-fold rise from baseline before dose 1. In this population of 198 individuals, the 1-month post-booster response was 99.5% after dose 3 versus 98% after dose 2, when both were compared to baseline. This yielded a 1.5-fold greater response after the booster with a lower bound of the confidence interval of minus 0.7%, well above the minus 10% required. Non-inferiority was also confirmed based on an FDA-defined alternative analysis. We were asked by the FDA in a post-hoc analysis to compare pre-booster versus post-booster seroresponse. And you can see that with this analysis in 179 individuals, the seroresponse rate was 93.9% post-dose 3 versus 97.8% post-dose 2, again meeting the minus 10% non-inferiority criteria with a percentage of the lower confidence interval being minus 8.2%. So, both the pre-specified GMT and seroresponse results, as well as the post-hoc alternative seroresponse rates, satisfied licensure criteria for a booster dose with neutralization GMTs greatly exceeding those seen after dose 2. Now I want to share with you the safety data that supports a booster dose. Follow-up time for the booster dose study is shown here. Total exposure from booster vaccination to the data cutoff date was a mean of...
Could you please wrap up pretty soon where you're running out of time?
All right. Let me get through the safety information. I thought we had 45 minutes. Are we running close to that?
You are.
Okay. We'll move quickly through this. Okay. Follow-up time for the booster dose study is shown here. Total exposure from booster vaccination to the data cutoff date was a mean of 2.7 months and a median of 2.6 months with the ranges shown. And the total exposure from dose 2 to the cutoff date, so including both exposure post-dose 2 as well as that post-dose 3, was a mean of 9.4 months and a median of 9.5 months. So let's look at the reactions solicited by eDiary after the booster dose compared to reactions after dose 2. Local reactions after dose 3 were comparable to those seen after dose 2. Reactions after dose 3 are in the bottom panel, dose 2 in the top panel, and I think you can see these recapitulated results that we saw in phase 1. This provides reassurance of comparable local reactions with the booster dose. Likewise, systemic events by maximum severity within 7 days of the third dose are similar to post-dose 2. Again, the same scheme, dose 3 in the bottom, dose 2 in the top panel. And I again draw your attention particularly to fever and chills, where in this larger data set you can see that if anything, the fever point estimate is lower than that seen for fever after the second dose in this cohort of 18 to 55-year-olds. Reported chills are also lower and other reactions are comparable to those seen after the second dose. This provides reassurance that the eDiary reactogenicity profile after a third dose is similar or perhaps even better than that seen after the second dose. Adverse events by system organ class occurring in greater than 1% of participants with 1 month post-dose third dose were less than those post-dose 2 in the parent study, with the exception of lymphadenopathy. Adverse events after dose 3 are shown in dark blue bars, adverse events after dose 2, light blue bars. At the top of the graphic chart, blood and lymphatic disorders at 5.2% is entirely represented by axillary lymphadenopathy. By comparison, after dose 2, 0.5% of the 0.6% in this category is also represented by lymphadenopathy. Generally, lymphadenopathy after dose 3 was mild, self-limited, and resolved. Lymphadenopathy includes one individual whose lymph node enlargement was judged severe by the investigator due to reported prevention of arm movement. It lasted for 5 days and resolved. For reactions other than blood and lymphatic disorders as shown on this graphic, the incidence of adverse events was typically lower or comparable after dose 3. These AE findings are reassuring regarding the safety profile of the vaccine. There were no SAEs or withdrawals due to SAEs in the 1-month period after the 3rd dose. Only one serious adverse event was observed with a median of 2.6 months of follow-up at the time of data cutoff, which was assessed as unrelated to the vaccine. This was a myocardial infarction reported 62 days after dose 3 by an individual in their 40s. The event was considered unrelated to study intervention by the investigator. This individual had a medical history pertinent to the etiology of the myocardial infarction, and the cardiac event was considered secondary to stimulant abuse. The myocardial infarction was reported as recovered or resolved without sequelae within 1 day of onset following treatment. Details of this case are included in the briefing document. You may recall a version of this slide from the emergency use authorization, which has been annotated somewhat to reflect the ongoing work that is done. You can see the nature of the pharmacovigilance that we are conducting. Pharmacovigilance activities are a critical component of activities relating to the detection, assessment, understanding, and prevention of risk. Pfizer has been conducting robust pharmacovigilance activities and collaborating with regulators and international groups. We will continue to look for rare adverse events such as myocarditis, anaphylaxis, as well as other adverse events of special interest. The current approach to pharmacovigilance has been valuable in detecting and assessing rare events and risks.
You're
and we will continue
really the end of your time, Bill.
All right. The evidence to date supports a positive risk-benefit for the Pfizer BNT vaccine. Let's go to the next slide, please.
We really can. You're really
right.
over your time. And FDA has to be able to speak.
Right, I understand. So let me just recapitulate. You've already had a chance. If we go to the next slide, please. Information has been shared with you earlier. You heard earlier from this morning, a 3rd booster dose restored high level of effectiveness for preventing both infections and severe COVID-19. And this table represents... All right. So I think that the point is that we obviously have seen a dramatic fold reduction by 11-fold for infection and 15.5-fold for severe infection that we believe a booster dose can restore. And with that, I will turn this over to Donna Boyce to wrap up.
Well, I think we've already had a wrap up. So thank you both very much. We will have a Q&A session later on in which you all will be able to participate. Let's go on now and hear the FDA presentation from Dr. Joo-Heen Lee. Dr. Lee, please.
Good morning, everyone. I am Dr. Joo-Heen Lee. I'm a medical officer at the Office of Vaccines and Research and Review within the Center for Biologics Evaluation and Research at the FDA. So here is an overview of the presentation today. I'd like to just mention that these slides are a collective effort of many members of the Office of Vaccines. So to quickly go through this, on August 23rd, 2021, FDA approved the BNT162b2 vaccine under the proprietary name of Comirnaty for active immunization to prevent coronavirus disease 2019 caused by SARS-CoV-2 in individuals 16 years of age and older. It's currently the only vaccine or medical product that is FDA approved for the prevention of COVID-19. And the BLA supplement being discussed today is intended to support approval for booster administration of Comirnaty approximately 6 months following the primary series. So I will start with the regulatory background with some key dates. In April 2020, starting on the left, the pivotal parent study C4591001 enrolled the first patient. In December 2020, an EOA was issued for the primary series in individuals 16 years of age and above. And in May 2021, this was extended to individuals 12 years of age and above. And on August 13, an EOA was issued for a third primary series dose for immunocompromised individuals. In August, as I previously mentioned, on the 23rd, we licensed the primary series of Comirnaty in individuals 16 years of age and above. So let me go through the booster study design. As previously mentioned, this starts with the parent study, during which over 44,000 individuals were randomized to receive Comirnaty or saline placebo, given two doses given 3 weeks apart. Now, after serial unblinding, a number of individuals received a booster dose. First, in phase 1, where 23 adults received their booster dose approximately 8.2 to 8.4 months after dose 2. And in 306 individuals from the phase 2-3 portion who received it in a median of 6.8 months after dose 2. Safety data were collected uniformly as shown in the boxes below, with solicited, unsolicited, serious adverse events, and deaths and serious adverse events that were deemed related to be collected for up to 2 years after dose 2. Now, I'll point out that the data to be discussed today will be from a subset of the 44,000, and so for the first 2 doses. We'll skip over. So just to give you an overview of the demographic profile for the booster dose participants, the phase 1 participants were very homogeneous, and as you can see on the bottom bar or section below, none were obese, none had comorbidities or history of SARS-CoV-2 exposure pre-dose 1. And the homogeneity is largely a function of the eligibility criteria for the study at phase 1 in development. And in the last column you see, as you've seen before, the profile for participants in phase 2 and 3. And you see some greater diversity in race, predominantly white at 81%, and some with history of SARS-CoV exposure at 3.6%. Any of the comorbidities deemed to confer increased risk for severe COVID, excluding obesity, was at 18.3% and approximately 40% with obesity. So we'll move on to the immunogenicity results. So the primary immunogenicity objective was to demonstrate non-inferiority of neutralizing antibody geometric mean titers against the reference or the wild-type SARS-CoV-2 strain USA Washington 1-like. Washington 1, I'm sorry, which is Wuhan-like. It was measured after the booster dose and compared to after the 2-dose primary series in the same individuals. And you can see in the pictorial above the 4 time points of interest that will be discussed in the subsequent slides. Another point to make is that the immunogenicity data were obtained using a validated virus microneutralization assay to quantify GMTs. So there are 2 co-primary immunogenicity endpoints for which non-inferiority was assessed. The first is the ratio of GMTs of SARS-CoV-2 neutralizing titers against the wild-type virus strain. And you can see here the ratio post-booster dose over post-dose 2. And here on the right are the criteria for non-inferiority. Lower bound, the 2-sided 97.5 confidence interval exceeding 0.67, and the point estimate of the GMT ratio of at least 0.8. The second immunogenicity endpoint that was analyzed for non-inferiority was the percentage difference of seroresponse at 1 month post-booster dose and at 1 month post-dose 2. Seroresponse is defined as at least a 4-fold rise, and this depends on a baseline measurement that is under the lower limits of quantification, and a post-vaccination measure that is at least 4 times that to be considered a seroresponse. And so what was being evaluated here, as pre-specified, was the percentage of individuals with a 4-fold rise from pre-dose 1 to 1 month post-booster dose, minus percentage of those with a 4-fold rise from pre-dose 1 to 1 month post-dose 2. And non-inferiority was declared based on the following criterion, with a lower bound for the difference in the percentage of seroresponders at these 2 time points being greater than negative 10%. So here are the immunogenicity analysis populations. Let me see here if I can get the little arrow. So starting at the top is the 306 individuals who comprise the all available immunogenicity population, and those were those who received BNT162b2 at 30 micrograms. And in the process of reaching the evaluable immunogenicity population, 44 were excluded primarily due to important protocol deviations. And then the number further slightly decreased to 234 because of the additional criteria of having no evidence of infection from dose 1 to 1 month after booster dose. And in the rectangle on the bottom is the definition of what was considered without evidence of infection. Okay. So here the slide shows the GMTs against the reference strain in the dose 3 booster evaluable immunogenicity population without evidence of infection. And on the y-axis on a log scale are the GMTs. And along from left to right you go from pre-dose 1, 1 month post-dose 2, right before post-dose, right before booster dose, I'm sorry, and then 1 month post-booster dose. And so you can see the trend that has been previously pointed out with the titers increasing dramatically after post-dose 2 with some waning within the 6 months prior to the booster dose administration, and a rise several significantly greater than that 1 month post-booster dose. So here I show the non-inferiority analysis based on the GMT ratios against the reference strain. And boxed in blue is the primary analysis population, which are the 210 individuals who were qualified to be in the evaluable immunogenicity population with no evidence of infection. And I'll point you to the rightmost column, which is the GMT ratio that we looked at comparing post-dose 3 to post-dose 2. The point estimate of 3.29 and the lower bound of 2.76 was clearly above the non-inferiority criterion that was mentioned before, which is the point estimate of being greater than or at least 0.8 and a lower bound of greater than 0.67. And here you see the pre-specified non-inferiority analysis based on seroresponse. And the rightmost column shows the endpoint. It's the difference in seroresponse between 1 month after booster and 1 month after dose 2. And the difference is at 1.5% with a lower bound of negative 0.7%. So this met the criterion set with respect to the lower bound of being greater than negative 10%. And as mentioned previously by Dr. Gruber, we did ask for an alternative or complementary analysis for which we asked them to define seroresponse using pre-booster rather than pre-dose 1 to define the seroresponders, or the difference in seroresponse between 1 month after booster dose and 1 month after dose 2. And as you can see here, the numbers are different, but these findings do not challenge the previous, the data from this previous slide, which shows that they've achieved non-inferior immunogenicity for the 2 co-primary endpoints. Okay, so here I'll go through the exploratory phase 1 analysis of virus neutralization titers against the Delta variant, as well as against the wild type or reference strain. As previously mentioned, the assay that was used to produce these data comes from a 50% plaque reduction neutralization test. And this was done in 23 participants against the reference USA strain and the Delta variant. And these titers were assessed in sera 1 month after dose 2 and 1 month after dose 3. And in the box in the middle of the slide are some considerations that the CRNT assay is not the same as the validated microneutralization assay for which we have immunogenicity data, which was presented in the preceding slides. It is well accepted and there was standardization, but it's not validated, and it was used for exploratory purposes. And the relative sensitivity for the 2 strains currently are unknown. So here are the results. On the columns are divided. You see on the left column Delta variant GMTs, wild type GMTs with confidence intervals. I have presented the 11, 18 to 55-year-olds on top of the older adults. And you see post-dose 2 here versus post-booster dose. So these numbers have been presented in the previous presentation. This is just arranged slightly differently, but you can see that neutralizing titers against the Delta variant and the wild type are present, measurable in both populations or age groups, and you see the difference between post-dose 2 and post-dose 3 uniformly across the 2 strains and across the age groups as well. Now, another post-hoc analysis that we requested from Pfizer had to do with breakthrough infections, particularly those that were detected during the Delta surge. And so what we asked the Pfizer was to provide numbers of protocol-specified COVID-19 cases that were accrued during the early July and end of August in participants 16 years of age and above. And on the left, you see we are looking at participants who completed the 2-dose vaccination series early in the study, or the parent study. So these refer to individuals who were originally randomized to BNT162b2. And among these almost 19,000 individuals, there were 70.3 cases per 1,000 person years. That's the incidence calculation that Pfizer provided. 3 were severe. This was collected over a period of 9.8 months post-dose 2. And on the right, you see we're considering the individuals who completed the 2-dose vaccination series later in the study. In other words, those who were originally randomized to placebo and then crossed over to the active vaccination group. Among these almost 18,000 individuals, there was an incidence rate of 51.6 cases per 1,000 person years. The mean duration was slightly less, as expected, at 4.7 months post-dose 2. So the data here suggests that the incidence of breakthrough infections appear to be higher in those who completed the vaccination series early versus those who completed it later. So in order to contextualize this delta in incidence, we did the following, we made the following calculation. Bubble number 1 on the left, you see the ratio that we set at the incidence rate among late vaccinees versus early vaccinees, and that came out to 0.73. And so the purpose of this calculation is to try to translate the relative breakthrough rate to vaccine efficacy. So we took this ratio of 0.73, and for each of the assumed efficacy values shown in the table below, among the placebo crossover group, we calculated the impact of this differential in breakthrough cases on the corresponding efficacy among those who are vaccinated earlier. So let me take you through one. If we assume that the efficacy of the vaccine, let's say for severe disease in placebo crossover recipients vaccinated later, then the differential in the incidence rate that was determined during the Delta surge would translate to approximately a 4% reduction in vaccine efficacy in those vaccinated earlier. Now, continuing on, so this is not actually during the Delta surge, but pre-Delta surge. If you look at the numbers, we consider the incidence of COVID-19 among early vaccinees from the evaluable efficacy population before the Delta surge occurred. And the case rate, or the incidence rate, was at 12.6 cases per 1,000 person years. And when you looked at the later vaccinees, the placebo crossovers, in this case before Delta, the incidence was actually higher at 43.4 cases per 1,000 person years. So the takeaway message is the data are complicated, and the limitations of the analysis are as follows. The parent study was not designed to assess the relative vaccine efficacy of the crossover group versus the original vaccinees. And therefore, this analysis is exploratory in nature, but still we thought would be quite informative or important to consider. In addition, the open label nature of the booster dose may have introduced confounding factors that include behavioral changes that biased the results. And of course, as mentioned previously, there are confounders that we are just not aware of at this time. Okay. So going on to the safety results. As mentioned previously, here the mean length of safety follow-up in the booster recipients in the phase 1 portion and the phase 2-3 portion were basically the same at 2.7 months and 2.6 months respectively. Here I am showing you the local reactogenicity data across doses, dose 1 and dose 2 data coming from the reactogenicity subset of vaccinees from the blinded portion or blinded phase of the study with an N of 2899 and 2682, and comparing this with the reactogenicity of those who received booster, the phase 2-3 participants in phase 1. And you can see here that injection pain, site pain continues to be the most common local reaction, and severity tended to be low with only one case, for instance, in the booster recipient. Overall, the data suggests that local reactogenicity does not appear to be enhanced following the booster dose relative to dose 2. Yeah, this is a busy slide, but so here are the systemic reactogenicity preferred terms that were recorded by eDiary 7 days after each dose. So along here, I've ordered the specific adverse reactions in descending order of frequency. So fatigue is the most common. Here you see the phase 2-3 dose 1 recipients, phase 2-3 dose 2 recipients, and the booster dose in booster dose recipients from the same phase. And fatigue continues to be the most common, and severity does not, the severity of fatigue does not appear to vary significantly from that observed after dose 2. And a similar relationship between all these other commonly reported systemic adverse reactions can be seen between dose 2 and dose 3. Frequency of fever slightly dipped after the 3rd dose, and use of antipyretics and pain medication were comparable after dose 2 as compared to after the booster dose. Okay, so here we're looking at the systemic reactogenicity profile by age strata. So the 289 individuals who submitted eDiary data were 18 to 55, and here this table only includes the individuals in the 65 to 85 year old age strata, and there were 12. And so if you look overall, the order of frequency of systemic reactogenicity is about the same, and it's worth pointing out that severe reactions of any kind in terms of systemic reactogenicity were not reported among these 12 recipients. Fever was also not reported. And the use of antipyretics or pain medication was also less. Now going on to unsolicited adverse events that were monitored 1 month post-booster. So here presented in this table are the most common events that occurred in more than 2 participants, or 2 or more participants, I should say. And the one worth pointing out is lymphadenopathy. It occurred in 16 participants with a corresponding frequency of 5.2%. The majority were mild to moderate, and they did resolve. All but 1 is reported to be as ongoing at this time. 1, as mentioned previously, was deemed severe due to impact on activity. This occurred 2 days after the booster dose and resolved over 5 days. Considering the time period of booster dose to data cutoff, which is at least 2 months of post-dose 3 follow-up in the 306 participants, there was 1 additional AE of acute myocardial infarction reported as an unrelated SAE. This occurred on day 62 post-booster dose and recovered and resolved. No participants were withdrawn due to adverse events, and among the 306 participants evaluated, there were no cases of anaphylaxis, hypersensitivity, Bell's palsy, appendicitis, or myocarditis, pericarditis. And among the 23 phase 1 booster recipients, there were no AEs that were reported 1 month after booster dose. So finally, I come to my last slide, which is a summary of the data that we reviewed that were submitted to this BLA supplement. So in terms of immunogenicity, success criteria against the reference strain were met for both pre-specified co-primary immunogenicity endpoints, which were the GMT ratio and the difference in seroresponse rates among study participants with no evidence of SARS-CoV-2 infection prior to 1 month after the booster dose. The immunogenicity data to support effectiveness of the booster dose against the Delta variant are limited to exploratory analyses in a small number of participants using an assay, while standardized and with a reference control is not validated to date. In terms of the safety data, from the 306 phase 2/3 booster recipients, there's no evidence that there is increased reactogenicity relative to dose 2. Difficult to reach conclusions about relative reactogenicity by age, or it is difficult to reach any conclusions about the relative reactogenicity by age, as there are only 12 participants, and in the age strata of 65 to 85, the minimum and maximum age range was 65 to 75. Lymphadenopathy was observed more frequently following the booster dose than after the primary series doses. So that's worth mentioning. There were no deaths, vaccine-related serious adverse events, or events of myocarditis, pericarditis, anaphylaxis, appendicitis, or Bell's palsy among the 325 booster recipients. And so I am done with my portion.
Thank you very much. It's time for our break. We will break until the open public hearing begins at 12:30 Eastern. So we've got a long 13 or so minute break until the open public hearing. See you back then.
Hey, it's Peter. I'm here.
All right, well, welcome back to the 167th meeting of the Vaccines and Related Biological Products Advisory Committee meeting. We will now get started, and I will hand it back over to our acting chair, Dr. Monto.
Welcome to the open public hearing session. Please note that both the FDA and the public believe in a transparent process for information gathering and decision making. To ensure such transparency, during the open public hearing session of the advisory committee meeting, FDA believes that it is important to understand the context of an individual's presentation. For this reason, FDA encourages you, the open public hearing speaker, at the beginning of your written or oral statement, to advise the committee of any financial relationship that you may have with a sponsor, its product, and, if known, its direct competitors. For example, this financial information may include the sponsor's payment of expenses in connection with your participation in this meeting. Likewise, FDA encourages you at the beginning of your statement to advise the committee if you do have or do not have any such financial relationships. If you choose not to address this issue of financial relationships at the beginning of your statement, it will not preclude you from speaking.
Okay, good afternoon, everyone. This is Saba Atreya, the designated federal officer for this session, who is going to conduct the open public hearing. And the next speaker, the first speaker for this session is Dr. Rajesh Gupta. Dr. Gupta, could you please start your presentation, please? You have 3 minutes to go.
My name is Rajesh Gupta. Currently, I do consulting for the pharmaceutical industry, including vaccine manufacturers. I have more than 40 years experience in development, manufacture, quality control, and regulation of vaccines, both in the industry and regulatory agencies, including CBER, FDA, where I was a deputy division director and lab chief. Today, I am going to present my views on some aspects about the need for a booster dose of COVID-19 vaccine based on my experience and understanding of science while working with other vaccines. Next slide, please. Major justifications for a booster dose have been waning with circulating and neutralizing antibodies and incidence of COVID-19 infections in vaccinated individuals a few months after vaccination. Next slide. A few facts about circulating antibodies. First, for most diseases, protective levels of circulating antibodies are not known. When known, for example, tetanus and diphtheria, these are highly variable. Next slide. Secondly, circulating antibodies decline a few months after vaccination. But booster doses are not given for most vaccines except for toxin-mediated diseases. Protection against most diseases is not necessarily through maintaining high level of circulating antibodies. I'm at slide 5 now, actually. Next slide. Instead of protection by most vaccines, is through rapid deployment of immune system by activation of immune memory by the invading pathogens, except for toxin-mediated diseases, where protective levels are required to be maintained, which is done through periodic boosters every 10 years. The reason is that tetanus and diphtheria toxins are highly potent. Minute doses of these toxins are lethal, but not enough to activate memory. Further, these toxins bind immediately to nerve cells and are not available to immune cells. Next slide. Other justifications for a booster has been incidence of COVID-19 infections in vaccinated individuals. However, there is no baseline data for protection against infections for most vaccines because, unfortunately, clinical trials were not designed to evaluate protection against infection. However, vaccines continue to be highly effective against severe disease. Next slide. Additionally, there is a risk of original antigenic sin phenomena after a booster dose. When antibodies to immunodominant epitopes are made, which get boosted after booster doses with immune memory, vaccination with a new strain or infection with a new strain hijacks the immune system towards the immune response to same epitopes for which antibodies were originally made. leading to no protection against the new strain after disease or vaccination. Next slide. Finally, booster dosage leading to high levels of circulating antibodies may generate escape mutants of SARS-CoV-2 virus. So to finally conclude, based on experience with the protection by existing vaccines, booster dose is not justified for general use at this time. It may be justified for immunocompromised or elderly who did not get adequate immune response after initial vaccination. Thank you.
Thank you, Dr. Gupta. The next speaker is Mr. Benjamin Newton.
Thank you. My name is Ben Newton. The question that we must ask every day is how we can save the most lives. The answer is to approve boosters and follow the American Academy of Pediatrics recommendation to approve pediatric vaccines in August before school started. Slide 2. The FDA guidelines for vaccine approval stated that vaccines are required to have 50% efficacy against symptomatic disease. Further, they require the use of the totality of the scientific evidence, such that if we only use randomized controlled trial data, we violate the FDA guidelines. Slide 3. We saw in April that vaccine efficacy is predicted by neutralizing titers. We have always known this would be the case, but now we had a correlative protection. Slide 4. Also in April, on the left-hand side, we saw that both variants and time would reduce vaccine efficacy. Boosters would be required. On the right side, we saw the 90-day half-life of antibodies. It was clear that we would need boosting in the fall of 2021 at the latest. Slide 5. In June, we saw that the Delta variant and Angola strains had immune escape. The question now became, do we have days or weeks to start boosting? Slide 6. In July, we had our answer. We had waited too long to start boosting. Israel published data showing vaccine efficacy had dropped below 50%, the FDA minimum standard for people vaccinated 5 months prior. Israel started boosting days later. We should have too. Slide 7. Does the FDA have an ethical obligation? Option 1 is that they don't have an ethical obligation, just an obligation to approve safe and effective medicines. Then they should approve both boosters and follow the American Academy of Pediatrics recommendation to approve vaccines for children. Option 2 is that the FDA has an ethical obligation. Then we must approve pediatric vaccines. We can't randomize pediatric trials 50-50 because that would be unethical, but there are 50 million American children who are not free to be vaccinated today. We should approve lower doses. I and others have explained to the FDA how to optimize dosing to save lives. If you care to watch a long-form explanation, you can check out the YouTube video here. In addition, we should approve boosters. If you don't approve boosters, then only people with good doctors can be boosted. Slide 8. The FDA had a reputation to protect. The FDA built its reputation by saving lives with thalidomide. With COVID, the FDA has squandered its reputation. The FDA lagged other regulators, often by months, in approving vaccines and diagnostic tests. Randomized controlled trials became unethical the instant we knew, or importantly, should have known that vaccines worked. If you fail to look at data, it does not mean the data doesn't exist. It is important to note that developing a vaccine took 2 days. We are quickly approaching 2 years. When will all Americans be free to be vaccinated? Slide 9. This is not the last pandemic or variant. The FDA must determine how to approve vaccines as fast as viruses spread. Boosting with wild-type vaccines increases the chance that vaccine efficacy will drop precipitously. I thank you for your time and service.
Thank you, Mr. Newton. The next speaker is Dr. Jessica Rose.
My name is Dr. Jessica Rose, and I'm a viral immunologist and computational biologist. I've taken it upon myself to become a VAERS analyst, to organize the data into comprehensive figures to convey information to the public in both published work and video mediums. Safety and efficacy are the cornerstones of the development and administration of biological products meant for human use. Risk is a measure of the probability of an adverse event occurring and the severity of the resultant harm to health of individuals in a defined population. Safety is a judgment of the acceptability of this risk in a specified situation. Efficacy is the probability of benefit to individuals in a defined population from a medical technology. Refer to slide 1. This is a bar plot that shows the past 10 years of VAERS data plotted against the total number of adverse event reports for all vaccines for the years 2011 through 2020 and for COVID-associated products only for 2021. The left bar plot represents all adverse event reports, and the right bar plot represents all death adverse event reports. There's an over 1,000% increase in the total number of adverse events for 2021, and we are not done with 2021. This is highly anomalous on both fronts. These increased reporting rates are not due to increased rates in injections and not due to simulated reporting. This has been shown using a comparative analysis of influenza data. The onus is on the public health officials, the FDA, the CDC, and policymakers to answer to these anomalies and acknowledge the clear risk signals emerging from VAERS data and to confront the issue of COVID injectable product use risks that, in my opinion, outweigh any potential benefit associated with these products, especially for children. Slide 2. This is a time series plot that shows the total cumulative number of cardiovascular, immunological, and neurological adverse events for 2021 associated with COVID products. When the cumulative absolute counts are normalized to the total number of fully injected individuals in the U.S., we can see that 1 in 660 individuals are succumbing to and reporting immunological adverse events associated with the COVID products. The underreporting factor is not considered here. Slide 3. This is a phylogenetic tree showing the emergence of the alpha and delta variants of the COVID-19 over time. The emergence of both of these variants and their subsequent clustering arose in very close temporal proximity to the rollout of the COVID products in Israel. Israeli data from the Ministry of Health and Our World in Data reveals that 98.1%
המענה הקולי של 0, 5, 4, 5, 4, 5, 5, 0, 8, 3.
Oh my God. Oh my God. Sorry about that. Israel is one of the most injected countries, and it appears from this data that this represents a clear failure of these products to provide protective immunity against emergent variants and to prevent transmission, regardless of how many additional shots administered. And this begs the question as to whether these injection rollouts are driving the emergence of the new variants. There's clear and present danger of the emergence of variants of concern if we continue with these alleged booster shots. Thank you.
Thank you, Dr. Rose. Next speaker is Professor Recep Levy.
Good afternoon, everybody. Good afternoon, everybody. My name is Recep Levy. I hope you can see my personal title slide labeled as slide A on the bottom right. I'm on the faculty of the MIT Sloan School of Management. I have no conflict of interest to disclose today, and my presentation represents only my individual opinions and does not reflect in any way on the positions of MIT. Next to slide B. Since the Pfizer's request for the approval of the boosters is partially based on the so-called study conducted in Israel, it is important to understand that the booster vaccination campaign in Israel was anything but a carefully designed study. In a matter of less than 6 weeks, Israel moved from its initial intention to vaccinate the over 60 population to vaccinating anyone above the age of 12, and it is now about to mandate booster vaccination for anyone to maintain green passport status. This does not allow any reliable learning, definitely not in such a short amount of time. And please understand that the adverse event surveillance system in Israel is truly dysfunctional, particularly around the booster deployment. I know from personal experience that the Ministry of Health in Israel does not address appropriately major concerning safety signals. Next to slide C. This leaves us with the question, what drove this massive booster deployment? Next to slide D. Trying to reach vaccine-induced herd immunity by reducing transmission rates will be consistent with the stated goal of the agreement that Israel signed with Pfizer, as you can see on slide D on the left-hand side. The problem is that by now we already know from mounting evidence that reaching herd immunity based on the current vaccines does not seem like a feasible or realistic goal. Not surprisingly, as you can see on the right-hand side of slide D, Israel continues to have among the highest infection rates per capita in the world. Next to slide E. You all listened to a presentation of the Israeli Ministry of Health that praises the efficacy of the boosters. I would like to caution this premature celebration and remind you that similar statements were made just 6 months ago around February on the 2 initial doses. Note on slide E on the right-hand side that COVID-19 deaths in Israel, in spite of all of the boosters, are on the rise, whereas in other countries, including many states in the U.S., they seem to be on downward trend at the moment. The data from Israel also highlights
that the main risk of serious COVID-19 outcomes is focused to a large extent among the completely unvaccinated population and almost entirely in the over 61. On the left-hand side of slide E, you can also see data from Table 1 in a research paper by the Ministry of Health in Israel that suggests that the benefits from the boosters compared to the prior 2 doses in preventing serious illness might be much more limited than desired. There is much more to say about the problems of the current booster efficacy study. Next to slide F. But let me conclude by stressing how important it is to transition from emergency strategies to long-term ones. Slide F outlines 5 important considerations in doing so. They are self-explanatory. I hope you will hold off of approving this booster for broad use, at least until such a strategy is developed. Thank you for your attention.
Thank you, Dr. Levy. The next speaker is Dr. Joseph Raymond.
Hello. Please, if you can go to my first slide. Hello, my name is Dr. Joseph Raymond, no conflicts to declare. I'm an emergency physician educated at Cornell Medical School. My residency was Charity Hospital in New Orleans, and I've been working in this region since. Where I work, over 65% of the population are not vaccinated. I'm here today to ask for help for those working the front line to help us reduce vaccine hesitancy. For this, we need larger trials that demonstrate the vaccine reduced hospitalization without finding evidence of serious harm. I know many think the vaccine hesitants are dumb or just misinformed. That's not at all what I've seen. In fact, typically, independent of education level, the vaccine hesitant I've met in the ER are more familiar with vaccine studies and more aware of their own COVID risk than the vaccinated. Next slide, please. For example, many of my nurses have refused the vaccine, despite having seen COVID-19 cause more death and devastation than most people have. I asked them, why refuse the vaccine? They tell me while they've seen the firsthand dangers of COVID in the elderly, the obese, diabetics, they think their risk is low. They're not wrong. Next slide, please. One nurse showed me this Oxford risk calculator. A 30-year-old female has about a 1 in 7,000 chance of catching COVID and being hospitalized over 90 days. She asked me, can I assure her that the studies found her risk of serious harm from the vaccine is lower than her risk of hospitalization? The truth is I can't. Our trials weren't big enough. They weren't big enough to identify the vaccines cause myocarditis, yet now we know they do. Next slide, please. A recent observational study suggests the risk of vaccine-induced myocarditis in young males is higher than their risk of hospitalization from COVID. Is this true? We don't know. It's based on observational data. To know it's not true, we need a large trial that proves the vaccines reduce hospitalization more than they cause myocarditis in this age group. Next slide, please. The former FDA commissioner said the original premise of the vaccine was to reduce death and hospitalizations. And that was the data that came out of the initial clinical trials. Except, as you all know very well, and unfortunately, so did my nurse, the initial clinical trials did not find a reduction in death or hospitalization, likely because they were inadequately powered. Yet the former commissioner is correct that the initial trials should have been powered to find a reduction in hospitalization. Next slide, please. We need your help on the front lines to stop vaccine hesitancy. Demand the booster trials are large enough to find a reduction in hospitalization. Without this data, we, the medical establishment, cannot confidently call out anti-COVID vaccine activists who publicly claim the vaccines harm more than they save, especially in the young and healthy. The fact that we do not have the clinical evidence to say these activists are wrong should terrify us all. Thank you. Next slide.
Thank you, Dr. Freeman. The next speaker is Mr. Steve Kirsch.
Hi, I'm Steve Kirsch. I'm Executive Director of the COVID-19 Early Treatment Fund. I have no conflicts. Advance to slide number 4 with the elephant. I'm going to focus my remarks today on the elephant in the room that nobody likes to talk about, that the vaccines kill more people than they save. Today we focus almost exclusively on COVID death saves and vaccine efficacy because we were led to believe that the vaccines are perfectly safe. But this is simply not true. For example, there were 4 times as many heart attacks in the treatment group in the Pfizer 6-month trial report. That wasn't bad luck. Theirs shows heart attacks happen 71 times more often following these vaccines compared to any other vaccine. In all, 20 people died who got the drug, 14 died who got the placebo. Few people notice that. If the net all-cause mortality from the vaccines is negative, vaccines, boosters, and mandates are all nonsensical. This is the case today. Death rates. Let's slide number 7, advance to the number 7 in the lower part. This shows that the all-cause death light rate in 3 cases. Only the VAERS numbers are statistically significant, but the other numbers are troubling. Even if the vaccines had 100% protection, it still means we kill 2 people to save 1 life. 4 experts did analyses using completely different non-U.S. data sources, and all of them came up with approximately the same number of excess vaccine-related deaths, about 411 deaths per million doses. That translates into 150,000 people have died. Next slide would be slide number 11, the nursing home. Now, the real numbers confirm that we kill more than we save, and I would love everyone to look at the Israel Ministry of Health data on the 90-plus-year-olds, where we went from a 94.4% vaccinated group to 82.9% vaccinated in the last 4 months. In the most optimistic scenario, it means that 50% of the vaccinated people died and 0% of unvaccinated people died. Unless you can explain that to the American public, you cannot approve the boosters. Slide number 16, please, myocarditis. The paper just posted yesterday on medRxiv entitled mRNA COVID-19 Vaccination and Development of CMR Confirmed Myocarditis shows that the myopericarditis risk was 1 in 1,000. And that's an overall age range from 18 to 65, mean age of 33. It is not inconsistent with what the VAERS shows. Next slide would be slide number 18, gaming of the trial. It's pretty clear that the Pfizer trial results were gamed. It's statistically impossible for protocol violations to be 5 times higher in the treatment group. Why hasn't this been investigated? Slide number 19. Maddie DeGray was 12 when she enrolled in the Pfizer phase 3 trial for kids. Now she's paralyzed for life. It wasn't reported in the Pfizer results. I told Janet Woodcock there was no investigation. Please tell us why this fraud was not investigated. And finally, slide number 20, please. Early treatments are a much better alternative to boosters. The proof is that in Israel, cases are at an all-time high. In India, Uttar Pradesh is now COVID-19 free as of today. Almost nobody there is vaccinated. Thank you.
Okay, thank you. The next speaker is Mr. David Wiseman.
Thank you, Dr. Monto. Please see our written comments. Next slide, B. For our disclosures, and next slide, slide C. With this Lancet paper by FDA vaccine officials, we find ourselves agreeing with them, but for different reasons. We have an unclear need with unclear motivation, significant safety concerns, poor evidence of sustained booster efficacy, and wrong priorities. So while FDA and Pfizer can't agree about waning efficacy, let's go to next slide, D. We saw recently CDC's apparent withholding of key data from ACIP prior to recommending the Pfizer vaccine, and revealing that the primary driver for approving Comirnaty was to overcome hesitancy through regulatory misdirection. We agree with others that this has become politicized. Next slide, E. Pfizer's booster evidence today is weak. They are small studies in mostly younger subjects. They are short-term. There is no randomized control. There are no clinical outcome data, only serology. Inadequate safety given this is a gene therapy product. Where are the data from the 10,000 patient study? Next slide, F. If FDA cannot assure us of the safety of 2 doses, how can they assure us of 3? We see strong signals for death, myocardial infarction, and coagulopathy that need transparent investigation. Next slide, G. We find 3 potential pools of vaccine-associated deaths. Note the second pool among vaccinees. Next slide, H. Daily cases in Israel increase upon booster rollout compared with the same period last year. Please note the correct rollout is July the 1st at the 130 number. The Israel booster presented today has matching censoring bias seen in related studies, non-comparable populations, possible clustering bias, inadequate accounting for early vaccine effects, and a short follow-up in mainly older people. Next slide, I. Others show unexplained Israeli deaths lockstepping with booster rollout. This looks like the second pooled deaths we said before in vaccinees rejected by New England Journal of Medicine in February. Next slide, J. Other safety concerns not voiced in the label are revealed in studies funded offline by NIH for menstrual disorders. Next slide, K. And offline by CDC in a disturbing revelation of an urgent need to monitor safety in pregnancy. Put this in the label. Next slide, L. Long-term safety. No cancer studies were performed. Moderna said its vaccine was a gene therapy product. Why is the FDA not requiring 5 to 15-year cancer and other studies per their gene therapy guidance? Next slide, M. We propose the term PCOVs to describe the wide spectrum of events being reported. Next slide, N. We are running out of options. Vaccine hesitancy won't be solved by bullying or coercion. Address safety, show convincing booster efficacy, revisit repurposed drugs. Next slide, O. We reverse the findings of flawed landmark studies that have misguided policy. Journals refuse to correct these defects, and Dr. Rubin's seat on this committee is a conflict. Next slide, P. This is what has to be done. Thank you very much.
Thank you. The next speaker is Mr. Kermit Kubitz.
Hello, my name is Kermit Kubitz. I have reviewed this presentation with other friends from Caltech. I have previously commented to the ACIP in December in support of EUA for the Pfizer vaccine. At that time, I said my only conflicts were elderly relatives who needed the vaccine yesterday. Since then, 2 of those 3 relatives have received the vaccine. One with rheumatoid arthritis has received a booster with no adverse effects. Next slide. The table of booster pros and cons. Reasons against boosters are lack of need in view of current efficacy, risks, confidence, and global vaccine equity. However, I believe there are substantial reasons for boosters, including normal vaccination protocol involves a delay of months. Boosters may limit infectious cases in large gatherings, and global vaccine supply will be from more conventional vaccines not requiring uninterrupted cold chain. Next slide. Balancing booster pros and cons. Breakthrough infections, although milder, are occurring. Vaccine hesitancy is generally not rationally based. A phased booster approach would allow greater global vaccine availability, and the United States could boost international vaccine supply by funding new lower-cost vaccines such as biological E. Next slide. Country approaches to booster vaccination support boosters. Canada, Italy, Greece, Britain, China, and France. Next slide. Conclusions. As my friend Chuck Wolf has commented, it's important to plan for boosters now, even if not everyone will receive a booster. There are 3 priorities. 1, the unvaccinated. 2, children 6 to 11. And 3, boosters for other people. There are outbreaks in schools that have nearly shut down schools in Raleigh, North Carolina. Booster vaccination should be offered beginning with age priorities, either 65 and older or 50 and older. Booster vaccination may offset, quote, social hesitancy of those who fear social interactions with anyone else and are thus isolated. But we should plan for boosters, and the Commission should promptly approve booster vaccination while dealing with the other priorities, the unvaccinated and school children. Thank you very much for your time.
Thank you, Mr. Kubitz. The next speaker is Dr. Peter Doshi.
Hi, I'm Peter Doshi, and thanks for the opportunity to speak. Hopefully you can see my title slide with my financial disclosures. For identification purposes, I'm on the faculty of the University of Maryland and an editor at the BMJ. I have no relevant conflicts of interest. Next slide, please, which is labeled Slide A. I want to start off by asking a question. Just what problem is this 3rd dose aiming to solve? If we have a pandemic of the unvaccinated, as our public health officials have repeatedly stated, why would a, quote, fully vaccinated person need a third dose? Next slide, B, please. The briefing document suggests the rationale for boosters is waning immunity, but the lowest vaccine efficacy figure mentioned is 83.7%. And last month, FDA approved Pfizer's vaccine stating that efficacy against symptomatic COVID is 91%. Sure, a third dose might nudge up efficacy numbers, but so too might a fourth dose and a fifth dose. The thing is, the two-dose regimen efficacy numbers are already way higher than the 50% bar that FDA set in June last year for an approvable vaccine. Before contemplating the licensure of dose 3, shouldn't FDA first require evidence that the two-dose regimen no longer meets the efficacy bar the agency just weeks ago said it met? If vaccine efficacy is now below 50%, let's see the data. Next slide, C, please. Let's discuss safety. When discussions about a third dose began in July, CDC Deputy Director Dr. Jay Butler said it was vital to find out if the third dose increased adverse reactions, particularly severe ones. Unfortunately, we're still in the dark. Pfizer's booster application reports on just 329 people with no control data. Now, there is a Pfizer ongoing placebo-controlled randomized trial of boosters in 10,000 people not discussed in the briefing document. But this trial is unlikely to satisfactorily characterize booster safety. First, the trial is too small and the enrollment's limited to healthy participants. Second, we really need to know how safe boosters are in people who already had bad reactions to dose 1 or 2. But such people are obviously less likely to volunteer to participate in this trial, so we won't have the data to answer the question. Yet if the booster is approved, such people will surely be mandated to receive a third dose. Final slide, D, please. I'll end with a question. Last week, 3 medical licensing boards said that they could revoke doctors' medical licenses for providing COVID vaccine misinformation. I'm worried about the chilling effect here. There are clearly many remaining unknowns, and science is all about probing unknowns. But in the present supercharged climate, and I'll point out that multiple members of this committee are certified by these boards, I want to ask FDA, what is FDA doing to ensure that those advising it are able to speak freely without fear of reprisal? Thank you for your attention.
Thank you, Dr. Doshi. The next speaker is Dr. Michael Karom.
Hello, I'm Dr. Michael Karom, Director of Public Citizens Health Research Group. I have no financial conflicts of interest. Public Citizens supported the emergency use authorization and subsequent approval of the Pfizer-BioNTech COVID-19 vaccine because clinical trial data demonstrated the vaccine was highly effective and generally safe. However, Pfizer and BioNTech have failed to provide sufficient evidence to assess the risk-benefit profile of a booster or third dose of their COVID-19 vaccine in individuals aged 16 or older in the general population. In particular, there is a lack of data on the effectiveness and its duration of booster vaccination in preventing important COVID-19 related outcomes, that is, serious illness resulting in hospitalization or death, in individuals aged 16 and older in the general population, and safety data for booster vaccination is very limited. Importantly, observational studies indicate that the primary series of the Pfizer-BioNTech vaccine still affords robust protection against severe COVID-19 disease and death in the U.S. We agree with the following assessment and conclusions offered by Drs. Gruber and Krause and other experts in their Viewpoint article published in The Lancet this week. Quote, current evidence does not appear to show a need for boosting in the general population in which efficacy against severe disease remains high. The limited supply of COVID-19 vaccines will save the most lives if made available to people who are at appreciable risk of serious disease and have not yet received any vaccine. Even if some gain can ultimately be obtained from boosting, it will not outweigh the benefits of providing initial protection to the unvaccinated. If vaccines are deployed where they would do the most good, they would hasten the end of the pandemic by inhibiting further evolution of variants. End quote. Finally, any move to widespread distribution of COVID-19 vaccine boosters in the U.S. would make it even more ethically imperative that the U.S. government move to ramp up global vaccine manufacturing so that everyone on the planet can be vaccinated. The world currently is suffering an artificial scarcity of high-quality COVID-19 vaccines because governments are permitting drug corporations to maintain monopolies. While the U.S. has been planning its booster vaccination campaign, the vast majority of people in low and middle-income countries have no access to any COVID-19 vaccine, let alone the highly effective mRNA vaccines. If the U.S. is to proceed with COVID-19 vaccine boosters, we take on a special, greater obligation to do everything in our power to get as many vaccine doses as possible, as quickly as possible, to people in low and middle income countries, and especially to invest immediately in expanded manufacturing to create an adequate supply to vaccinate the entire world. Thank you for your attention.
Thank you, Dr. Karam. The next speaker is Kim Witzak.
Hi. My name is Kim Witzak with Woody Matters, a drug safety organization started after the death of my husband. I'm also on the board of directors of USA Patient Network and have no conflicts of interest. It seems we are here today to discuss Pfizer's application to redefine the meaning of fully vaccinated from 2 to 3 doses. From the beginning of the pandemic, the goalposts keep changing. It makes you wonder if the current vaccination strategy is working. When looking at the submitted data, it's just over 300 people with only 12 of them over age 65, the highest risk group, sufficient enough to warrant approval for boosters. If the FDA approves this, we will take what we've learned on just 300 people and then give it, no, more like mandate it to hundreds of millions of people. This is beyond preposterous. While I am no vaccinologist, it would seem logical that dose 3 would have an increase in immune response over 2, 4 doses over 3, 5 over 4, and so on. At what point will enough be enough? At the end of the day, can we really vaccinate our way out? While boosters may be good for business, let's be real. These mRNA vaccines were never designed to stop transmission or eradicate the virus. These vaccines are not the same as those being used to eradicate polio or smallpox. I have to wonder why we chose to go down the vaccine path first versus focusing on treating those with a COVID diagnosis before it was too late or ended up in the hospital or worse yet, dead. And also, we haven't heard any discussion from our national leadership on the role natural immunity plays. Instead, NIH, CDC, FDA, and the White House have told Americans that vaccines are superior to our innate immune systems and beat out any natural acquired immunity. Let's take a step back and look at the bigger picture. First, our government incentivized, more like bribed, the public to get these shots. Then we were told about the possible need for boosters while shaming and blaming the unvaccinated. Now the government is forcing them with mandates. Is there a reason we want everyone to be vaccinated? Is it so adverse events can't be distinguished between vaccine and the virus? Or is it to help masquerade the waning effectiveness of vaccines and blame the new variants when it may just be the mutating virus escaping leaky vaccines? Politics and fear seem to be in the driver's seat. Facts around data and science can no longer be questioned or openly debated without being discredited or labeled as misinformation. Just look at what the professional medical societies are collectively doing, threatening doctors with losing their medical license if they deviate from the official protocol or narrative established by CDC and public officials like Dr. Fauci. People are not able to talk about their negative experiences without being dismissed, harassed, or being called an anti-vaxxer. Just look at what happened to rapper Nicki Minaj this week. People came out and attacked her for telling her family story and voicing an opinion. We are walking a slippery slope when regular people, celebrities, doctors, and scientists are silenced, or worse yet, censored. Finally, I would be remiss if I failed to mention the hundreds of thousands of people who paid the high price by doing the right thing for the greater good. Their lives have been forever changed. I don't have enough time to begin to touch on the currently reported safety issues impacting tens of thousands, including children and young adults, and all the future safety issues not yet realized. Ladies and gentlemen, we are part of the largest pharmaceutical experiment ever conducted on humankind. Thank you so much, and I appreciate your deliberation.
Thank you, Ms. Witzak. The next speaker, Paul Alexander, we could not connect him, so we'll try it later. So we'll move on to the next speaker, Ms. Linda B.
Hi, yes, my name is Linda D. I have no conflicts. I have been a community rep on many CEDAR antiviral advisory committee hearings. Emphasis on the unvaccinated and international vaccine donations from the U.S. Issues are misplaced. FDA does not have the power to increase international vaccine donations or create policy to promote increased vaccinations at home or abroad. We are here because there are differing opinions on whether there is sufficient data to support licensure of a third dose of BNT 162b2 for people 16 and older. The sponsor is relying on data from a number of sources that show activity wanes between 6 and 8 months after the second dose. Data also suggests that breakthrough cases were caused by waning effectiveness, not the Delta variant. Sponsors also conducted a sub-study within their registrational study that eventually established safety in 306 participants 18 to 55. I think the Israeli safety data was helpful even if it was in mostly older people. The third 16b2 dose was found to be as well tolerated as the second dose and elicited responses to wild-type virus not inferior to the second dose response. The sponsor believes the FDA development guidance permits these data to be extrapolated to include individuals 16 and 17 as well as people over 55. Has the sponsor provided sufficient data from adequate clinical trials to justify their request for licensure? Reasonable people strongly disagree, as is evidenced by the different positions taken in recent New England Journal and Lancet articles. I've been an AIDS activist for some 35 years. I understand only too well the need for access, but I have learned the importance of evidence-based medicine the hard way. We all rely on the FDA to ensure that interventions are safe and effective. If you do not believe that data are sufficient to justify full approval, please consider the innovative practical solution of accelerated approval, which we've used in the HIV arena for many years, which also permits and is also permitted in some circumstances for vaccines according to the general principles for the development of vaccines to protect against global infectious diseases guidance, even though this guidance addresses international issues. Accelerated approval will permit access and requires the sponsor to conduct or complete at least one adequate, well-controlled confirmational trial before full approval is granted. This option should be considered as it provides the best solution for both the access and additional data dilemma questions presented here. Thank you.
Thank you, Ms. D. The next speaker is Dr. Meg Seymour.
Thank you for the opportunity to speak today on behalf of the National Center for Health Research. I am Dr. Meg Seymour, a senior fellow at the center. We analyze scientific data to provide objective health information to patients, health professionals, and policymakers. We do not accept funding from drug or medical device companies, so I have no conflicts of interest. Today, you're asked to discuss whether the data presented support the safety and effectiveness of a booster dose of the COVID-19 vaccine, and if so, for whom. I will focus on the safety sample data discussed in only 329 patients. Even more important, the sample is not representative of the people who will want the booster. There are safety data on only 12 patients ages 65 and over, even though people over 65 are considered a priority group for a booster due to weaker immunity. 12 people over 65 is much too small to draw conclusions about safety and is obviously not large enough to have any confidence in the claim that adverse events from booster doses are less common in those 65 and over. In addition, there are 0 patients ages 16 and 17, and safety for this population is being extrapolated based on safety for those 18 and over. Data should be collected for any population that the boosters would be approved for, rather than extrapolating pediatric safety from adult safety data. Unfortunately, the size of the sample is not the only problem with the safety data. A median of 2.6 months is not enough time for assessing the safety of the booster. In addition, we agree with the FDA that it is unknown whether there will be an increased risk of myocarditis, pericarditis, or other adverse reactions after a booster dose. We all know that COVID can be deadly, but the efficacy of a booster compared to no booster is not well established, since the placebo control group is missing in addition to uncontrolled variables that could influence the diagnosis of COVID for those with boosters and those vaccinated without boosters. Assurance that the benefits outweigh the risks should be gathered before approving booster vaccines. Otherwise, potential risks may become obvious only after large numbers of the general population have received boosters, and the benefits of boosters may be much less than expected. FDA decisions should be based on proof of the safety and effectiveness of a medical product before the product is widely distributed. To approve a booster without adequate safety or efficacy data undermines the integrity of the FDA. It is unfortunate that the White House announced the need for and availability of boosters prior to FDA's assessment of the data. We know numerous people who have already received booster doses by merely asking their doctors or local pharmacies for a third dose. We all want to get the COVID-19 pandemic under control and protect as many people as possible, which is exactly why it is so important to carefully and scientifically assess the safety and effectiveness of COVID-19 booster vaccines. The data provided for this meeting do not allow us to draw confident conclusions, and a premature decision will make it impossible to do the research necessary to draw scientific conclusions. Thank you.
Thank you, Dr. Seymour. The next speaker is Ms. Kathleen Cameron.
Good afternoon. My name is Kathleen Cameron. I'm a pharmacist, public health care professional, and Senior Director of the Center for Healthy Aging at the National Council on Aging, or NCOA. I have no conflicts to declare. I appreciate the opportunity to provide comments today on behalf of NCOA, older adults, their family members and caregivers, and organizations that serve them. NCOA is a respected national leader and trusted partner to help people aged 60 plus live with health and financial security. We believe every person deserves to age well. Vaccines are a vital part of aging well, and NCOA is committed to ensuring older adults have accurate and timely information about them to avoid confusion when making decisions. We also advocate for access to approved vaccines using public benefits for which older adults are entitled. Older adults have been disproportionately impacted by the coronavirus pandemic. Those 65 and over represent 13% of COVID-19 cases, yet account for nearly 80% of the deaths. COVID-19 also is having a disproportional impact on communities of color who have always had to face health disparities such as higher rates of chronic conditions, income inequality, and inadequate access to quality health care. The older adults in these communities have historically fared even worse. Further, we now know that older vaccinated people are most vulnerable to illness and hospitalization after a breakthrough infection. As the CDC recently reported, this may be due in part to waning immunity that is most significant in people aged 65 and up, who are at greatest risk for hospitalization and death from COVID-19. NCOA commends BURPAC's diligent and rigorous work as our country continues to face the evolving COVID-19 pandemic. Every day brings new knowledge about the virus, the effectiveness of COVID-19 vaccines, and the potential need for vaccine boosters, as discussed during this meeting today. The impact of COVID-19 pandemic on older adults has been tremendous, and we want to do all we can to protect older adults, as well as healthcare and long-term care workers, as we continue to learn more about the long-term effectiveness of COVID-19 vaccines. We are counting on the FDA to conduct gold standard reviews and to develop appropriate recommendations as you have done so well for many years. We ask that you carefully examine all available data on safety and effectiveness of COVID-19 vaccines over time among various population groups, especially older adults who are most vulnerable, and make your decision about booster shots as expeditiously as possible. Thank you again for the opportunity to provide comments, and we welcome further discussion and involvement as decisions are being made. Thank you.
Thank you so much. The next speaker is Ms. Beth Battaglino.
Hi, thank you all for allowing me time today to present on behalf of Healthy Women. I'm Beth Battaglino, President and CEO of Healthy Women. We were founded in 1988, and Healthy Women is the leading nonprofit women's health information source with a mission of educating women ages 35 to 64 years of age to make informed health choices. Throughout the years, we have informed consumers and healthcare providers about the advances in women's health, from the latest information on diseases and conditions to various milestones pertaining to access to care. We ensure that women have accurate, balanced, evidence-based information so that they can make informed decisions in partnerships with their healthcare providers. We also educate our audience regarding innovations in research and science, as well as changes in policy that affects women's access to treatment and care, so that women are prepared to self-advocate for better health outcomes. We know the importance of the process, and as we continue to educate our audience that the COVID-19 vaccines, like other drugs, are only approved following an established gold standard review process, COVID-19 vaccine development follows the FDA review process that includes research, multi-stage clinical trials, robust regulatory review and approvals, and ongoing safety monitoring. We also know that data on booster shots for all 3 vaccines continues to be studied, and we anticipate more information from the FDA and the CDC very soon. And Healthy Women will be ready to share out medically vetted, science-based research information on the booster shot with our audience of over 1.5 million women. Thank you.
Thank you, Ms. Battolino. The next speaker is Brian Husdick. Sorry if I didn't say your name right.
Thank you for the opportunity for health advocates to provide direct feedback. I have no financial conflicts to disclose. I'm Brian Hudidge, Executive Director of Health HIV, a national nonprofit organization based in Washington, D.C. We advocate for communities impacted and affected by HIV. Today I'm speaking to you as a health services advocate in an effort to get us all one step ahead of breakthrough infections among fully vaccinated people. While data clearly show that COVID-19 vaccines are highly effective against current strains, preliminary data also indicate that protection against infection overall appears to be waning, and that concerns us because it puts the populations we serve at even further risk for infection based on the point-in-time immunity of the general population. COVID-19 is a serious and potentially fatal and life-threatening virus, not just for those most at risk, like the immunocompromised and immunosuppressed, but for everyday Americans, especially front-facing service sector minority communities and marginalized populations in geographies with the highest viral load concentration, often a result of vaccine hesitancy or opposition. Not surprisingly, breakthrough infections appear to be more common among those with weakened immune systems. And according to data presented at a CDC Advisory Committee on Immunization Practices, immunocompromised patients represent 44% of hospitalized COVID-19 breakthrough cases, even though they only make up about 2.7% of the total population. As part of this data look back, the FDA evaluated the science on the use of a third dose of the Pfizer or Moderna vaccines in people with compromised immune systems, and they rightly determined that a third vaccine dose may protect them and others around them. In fact, they interpreted the findings to state that targeted policies like the booster shot being proposed today need to evolve as both science and risk evolve. It confirms that people with underlying conditions like advanced HIV, cancer, organ transplant, hemodialysis, and those on immunosuppressive therapies are seen as a significant risk for poorer outcomes from COVID-19. In essence, it highlights the need for our populations to stay as healthy as possible, but it also depends on the health of those around us. Fortunately, the vast majority of breakthrough infections are typically mild, but we are discussing the rationale for a booster shot in efforts to prevent the clock from winding backwards. We encourage the advisory committee to recommend booster shots for people age 16 and above, just as you did to protect people living with HIV. Thank you.
Thank you so much. The next speaker is Dr. Paul Alexander.
Hi, thank you very much. I got cut off earlier, but thanks for patching me back on. That's good work by you guys. Look, I wanted to get into this by saying my background is in evidence-based medicine, clinical epidemiologist, and I'm very interested in the safety and efficacy of these vaccines. I'm following some very good presentations so far. Look, we want these vaccines to work as Americans and as global populations. So I think the message has to be that we're not coming at the FDA or we're not coming at the CDC trying to raise issues and just... Can you hear me?
Yes, we can hear you.
Yes, it's not that we want to raise issues and concerns, but here's the issue. We want it to work. But when we look at the surveillance, coming out of the VAERS right now, CDC, it captures 1% to 10% by our study of the published literature of the adverse events. And that is very suboptimal because it doesn't give a proper capture of the burden. So we really do not know what the adverse events and the deaths are. So we want proper safety monitoring boards. We want proper ethics committees following up on these vaccines. We are calling for critical event committees that we do not seem to know whether they exist. So we want the FDA to get on top of these vaccine developers and the CDC and put this in place for the safety of Americans. And it's a simple issue. You are giving us vaccines, and this is what we have been clamoring for. If you have an investigation of a vaccine with 1,000 samples, you put 500 in each arm, and you follow that for 1 year, versus you have another study of 100,000 people, and you follow that for 2 months. And the safety events that we are looking for, the safety signals happens at about 5 to 6 months. How could that larger sample detect them? And that's the issue. We are calling for longer-term studies, larger sample size, but longer-term. We need the medium and long-term studies to best assess the safety and efficacy, particularly safety, particularly when you're talking about putting these vaccines in our children's arms. We currently do not have the safety data. We absolutely do not. And for anyone at the CDC, anyone at the NIH, and anyone at the FDA to claim so, that is being disingenuous to the public. Now, I wanted to end by saying this. When I looked at a study this morning by Chen on testicular infection post-CoV, SARS-CoV-2 virus. That means that there is an issue, and we are extrapolating based on the Japanese data that looked at the lipid nanoparticles and the mRNA that were accumulating in the tissue in the rat model. Yes, it's a rat model, but we have to extrapolate to humans. That showed that the lipid nanoparticle, the constituency of the vaccine, is accumulating in the ovaries, in the testes, in the spleen, in the adrenals, etc. So when somebody like Nicki Minaj, I have to invoke this, makes that statement, that's not a joke. People want to make this a joke and parody it, etc. But this is a very, very serious consideration because we even have animal data that shows us that there's a drop in fertility in the animal model. So we need this properly investigated. The public needs this answer properly. And I want to end by saying this. Under no condition, none, zero, based on the evidence today, must children be indicated for these vaccines. There is no risk to children, no statistical zero in terms of spreading and in terms of getting serious illness or dying from this. Dr. Martin Makary at Johns Hopkins, they looked at all of the death. Hello?
Yeah, we're out of time, sir.
Okay, thank you.
You can wrap it up.
Yes, we looked at the children in America that have died, and we found that save one, these children had at least one severe illness. So the reality is COVID is not a life-ending, life-threatening situation for children. Right now, CDC and the NIH have not prosecuted the case as to why these children should be vaccinated, period. I say do not do this, and I beg your consideration. Thank you.
Thank you. At this time, we will conclude the open public hearing, and then I will hand over the meeting to Dr. Manto, the chair. Dr. Manto, take it away. I think we are getting to a break now. Would you announce the return time, please?
Okay. I think we now have a 10-minute break, so our busy workers who've been handling the open public hearing have a little break for themselves, and we will reconvene in 10 minutes from now.